I need to be here.
Can share the screen.
Yes, share the screen and now let us go live.
So we'll go live.
Yes.
Deepak, can you share the slide?
Yeah, Shahana, just a minute. I'll do that. Is it visible?
Enough.
Yeah, now
Yes.
yes. Put in the slideshow mode.
Yeah.
Okay.
So we start, sir.
Yes.
Good morning, doctors. Sana, we are live.
Yes, yes.
Yeah.
Selva Kumar.
Good morning, doctors. A warm welcome from Zydus and Tapisar. Today, in this Sunday morning, I am delighted to see the galaxy of stars from cross section of India, from west to extreme south. We today have in this viewer mode all the who's and who's of infertility. And I think yesterday, once we celebrated World IVF Day, today is the best day we can have all the galaxy of stars for a great academic discussion organized by Tapisar with Zydus as academic partner. Zydus has always been in the forefront to promote education, and I am proud to associate today with Tapisar. And I convey my heartiest thanks and regards to our two chairpersons who are legendary figures from the country, Dr. Kamla Selvaraj and Dr. Sanjeeva Reddy. Today, I am delighted to introduce Dr. Kamla Selvaraj, who hardly needs any introduction in this platform, nationally or internationally, because she is a well-known figure all across. When I talk of Dr. Kamla Selvaraj, the first thing that comes to my mind is she was the first lady to deliver. She commissioned the first test tube baby of South India way back in 1990. And since then, there has been many achievements to her credit. She is currently Associate Director, GG Hospital Fertility Research and Women's Specialty Center, Chennai. We all know she is the daughter of famous yesteryear cinestar Padma Shri late Mr. Gemini Ganeshan. If I have to read Madam CV, I think it will take half an hour because she has got so many credentials to her account. I will still mention a few that she has published many papers in national and international journals and she had been moderating a lot of international and national conferences too. She had received many awards to name a few. In 1991, Rajiv Gandhi National Unity Award, 1993 Best Lady Doctor Award, 1995 Mahila Shiromani Award, 2017 Lifetime Achievement Award by ACE Hyderabad, 2018 Shakti Lifetime Achievement Award, 2018 again Eurofort 2018 Lifetime Achievement Award, and we can see in our screen that there is a list of awards which follows to her name. Last but not the least, she has achieved more than 25,500 babies which have been successfully delivered. I welcome you, madam, and we are proud and delighted to be here with you. Thank you. Now I am again delighted to introduce Dr. Sanjeeva Reddy, a person again who does not need an introduction. He is a famous figure all across the country, the professor and head of the Department of Reproductive Medicine and Surgery, Sri Ramchandra Institute of Higher Education and Research in Chennai. Dr. Reddy is first department university college to start in a super specialty course in OBGY. An excellent academician, a voracious reader, and sir has been mentoring so many students all across the country. Again, if we look into sir's credentials, it's a laundry list of all so many awards and achievements to name a few. Special award Dr. BC Roy National Award in 2015 as eminent medical teacher, expert panel member to Medical Council of India to formulate syllabus and minimum eligibility criteria for MCH in reproductive medicine and surgery course. He have been expert member to prepare syllabus for reproductive medicine to NTR University of Health Sciences Vijayawada, honorary consultant and external board member to JIPMAR, He had been the past president of OBGY Society of Southern India, Chennai, organizing secretary of All India Congress of AICOG 2015. He is the organizing secretary for Indian Society of Associate Reproduction Annual Conference in Chennai in 2015, where all of us was present, and organizing secretary Yuva ISAR 2018 in Chennai. The teacher of teachers, I welcome you, Dr. Sanjeeva Reddy, and thank you and Dr. Kamla Selvaraj for giving Zydus the opportunity to collaborate with Tapisar today. And at the same time, I welcome all the delegates. We have more than 120 delegates in today's morning session. So I'm sure as the day progresses, we will have more than 300. And a warm welcome to all the esteemed dignitaries and faculties that we have today to join us for this wonderful academic meet. Thank you, and over to Dr. Reddy and Dr. Kamla Selvaraj.
Thank you, Sudeep, for your kind introduction. Good morning. On behalf of Tapisar, I welcome all faculty and delegates for this 11th ECME through webinar during this pandemic. For the last 3 weeks, we have conducted the CME by involving Southern India state chapters of HISAR, Northern India state chapters of HISAR, and Eastern India state chapters of HISAR. This week, we have involved Western India chapters of HISAR and past presidents of HISAR and other senior reproductive medicine specialists of India. I thank all the chairpersons, secretaries for their cooperation. Faculty, if you see, you can see the speakers list. We have assembled top names in the field of reproductive medicine in India. The moderators also were experts in the field, and they will try to keep the sessions live and also will make the speakers to clarify all your queries. I thank each one of them for accepting our request to participate in this webinar in spite of their busy schedule on a Sunday. And the topics, you can see the topics, each topic is important and from basic to advanced, and they're going to highlight us with their personal experiences. It is up to you how to utilize them and to update your knowledge that will change your way of practice from tomorrow. I request our president of Tapisar, Dr. Kamla Selvaraj, to say a few words and introduce the moderators for the first session. Thank you.
Good morning. Good morning. Am I audible?
Yes, madam.
Good morning to everybody, graduates, undergraduates, postgraduates, budding practitioners. And thank you, Dr. Sanjeev, for such a elaborate, continuous, never-ending seminars, webinars, which helps everybody to gather the knowledge. Now, I welcome all of you to this interesting webinar. And I start with introducing Dr. T. Syllabus Selvi, MD, DGO, DNB, UG undergraduates and DGO from Madurai Medical College, MD, OG from Stanley Medical College, RSRM, DNB from Delhi. Worked as Associate Professor at Coimbatore Medical College and Hospital. Received an award in 2005 from the District Collector for performing maximum number of lab sterilizations in the government sector. Wow. Underwent infertility training from various renowned centers. Established Vamsam Fertility Center for Research Center in 2007 at Coimbatore. Expanded her centers to Tirunelveli, Trichy and Ooty. Conducts postdoctoral fellowship course in reproductive medicine, affiliated with the Dr. MGR Medical University, received Arctic Award for Best Fertility Center in 2012, KG Foundation Achievement Award in 2017, Mayan Award at Malaysia for her monumental contribution offering low-cost healthcare 2018. Visha Awards for Best Fertility Services in 2019. I welcome you, Dr. Syllabus Selvi. The next speaker. Okay. Next speaker, Dr. Kanchana Devi, DGO, DNB. And she is, of course, Senior Consultant in RMU, Cloud9 Hospitals, Chennai. MBBS, DGO, Madras Medical College, Chennai. 1992-1996, DNB, OG, Southern Railway Headquarters Hospital, Chennai. Fellowship, Christian Medical College, Bello, active in teaching and research. Presented papers in ISA 2009, 14 and 15. Contributed a chapter in the postgraduate textbook Essentials and Gynecology Volume 3. Invited speakers and resource person in national and international conferences published scientific research papers in national and international journals, organizing secretary and chairperson of several conferences and member of ISHTAR and OXI. The next speaker, Dr. Kanimuri. Welcome, Kanimuri.
Good morning, ma'am.
Fertility specialist, Apollo Women Hospital at Apollo Fertility, Chennai. She is the first in the country to complete MCH, reproductive medicine and surgery from Sri Ramachandra University in the year 2015. She has finished clinical embryology at Monash University, Australia, my favorite place. He has presented papers and posters in national and international conferences, has done research work on FSH receptors polymorphism in art. Great work. I welcome you, Kanimuri.
Thank you, ma'am.
All the moderators are now, I'm sorry, then hand over to the moderators to introduce the speakers. Thank you so much.
Shall I start?
Yes, Madam. Selvi, Madam, you can introduce the first speaker.
Yes, sir. Yes. Good morning. Thank you, sir and ma'am, for this opportunity. It is my privilege to introduce Dr. Kedarnath, who did his UG from Goa Medical College Hospital and Masters from Mumbai University. Diploma in IVF and ICSI, Sydney, Australia, 1999. He is practicing as an obstetrician and gynecologist and consultant since 1981 till date. Treated over 40,000 patients of infertility in 26 years with over 14,500 pregnancies, delivered more than 1,500 IVF babies. Given talks and lectures in 125 CMEs all over India. Published many research papers in India and abroad. Got the Best Paper Award in Jimakan 2013 for paper on genital prolapse. One interesting thing, he invented cruciate suture of Goa, an operation for rectovaginal prolapse. He conceptualized One World in December 1979 for unification of world. He has written a book, One World, that is World Without Borders, available on Amazon. I am planning to read it soon. Over to you, sir.
Thank you very much, sir. Madam, Dr. Kamala Selvaraj and Dr. Sanjeeva Reddy and Tapisar for allowing me to speak on this August forum. And of course, Zydus. Thank you, Madam Silam, for introducing me so augustly. We'll start with the talk on IUI. I will go to the screen sharing now and let me know if you can see the screen. We have to understand that can you all see the screen?
No, sir, not yet.
No, sir. No, sir.
I've started the screen sharing.
Just.
Green button, sir, but down. Press on the screen share. Did you open your presentation on the screen?
Yes.
Okay. Now press on the green button here. Go down. Share screen.
Yeah, it's coming
okay.
up, sir.
Now,
Yes.
Okay.
Yes,
put
Yeah.
in the slideshow mode, sir.
It is seen now?
Put in the slideshow mode.
Slide sharing.
Slideshow.
In full screen, sir.
so you can just press F5.
Try hitting F5, sir. F5 on the keyboard.
Next, that one.
Yes,
Yeah.
yes.
Good to go, sir.
Thank you once again. IUI is a topic which we all have gone over through again and again. So why discuss more about IUI? The point here is that if we can have the patient conceive with IUI, you have saved her the trouble of IVF, which is far more technically advanced, more taxing psychologically, spiritually, financially, and also it leaves back a scar if you fail. And as you know, the success rates are not more than 50%. If an IUI success is achieved, it's the best thing that you can give your patient. Therefore, it should be treated with equal importance as embryo transfer. I always tell when I treat your IUI like you're doing an embryo transfer. What we are trying to do is we are trying to sperms, the debris, the seminal plasma, and introduce the best sperms closest to the time of ovulation. And this is how we will achieve a pregnancy with a higher percentage than the 10 to 12% which is internationally acclaimed. The idea is to transfer the best sperms from the ejaculate at the correct time of ovulation closest to the ovulation. I keep on saying this again and again. The success of IUI is a jigsaw puzzle. It starts with indication and correct selection of the patient in the ovulation, monitoring the patient properly, give a correct trigger, have a processing which should be done by the embryologist, and the clinician should supervise and or take a look at it under the scope. Do very careful insemination, arrange and make sure that she gets proper luteal support. Thereafter, a pregnancy should be achieved. So it's a jigsaw which we need to put in place. One thing I would like to say here, and that is there are certain points to ponder on. Proper selection of patient is extremely important. You have not selected a patient properly and you get a failure. It's a problem of the procedure. It's the improper patient selection. And various factors will influence your outcome. We need to look at them carefully one by one. A good controlled ovarian stimulation has to be done. Monitor the cycle yourself. Give a ovulation trigger which is adequate to that patient. Give a UFOA support, and I'll give you some tips to improve the IUI success. Most of the times, the indications are male factor subfertility, unexplained infertility, diagnosis, combined ovulation and male factor problems, cervical and immunological infertility, or sexual dysfunction. The age of the female partner matters a lot. And many studies say that if the age is less than 35 years, the chances are less. But what if a patient comes to you saying that she's married at 42? Will you refuse her? It's not so. We could still give her a trial of IVF, and if it doesn't work, then go for IVF or further treatment. The cause of infertility is important. Remember that one tube should be completely normal and there should be no uterine factors. And of course, patient should have adequate ovarian reserve, which we all have to assess based on her serum AMH and antral follicle count. The patient selection parameters as far as semen is concerned are also very important. We must understand that post-wash total motile semen count should be more than 5 million per ml. Best pregnancy rates are achieved with, of course, more than 10 per ml, maybe even 5 million per ml if the post-wash count is good. If the post-wash count is less than 2 million per ml, don't waste time with IUI. Straight away advise her for IVF. Contraindications, as we all know, if there are tubal blocks, don't fool yourself. Don't tell that something is possible. Push her on to the next level of treatment, either laparoscopic tubal cannulations or IVF. If there is severe oligosteanoteratozoospermia, if there is genital tract infection or unexplained genital tract bleeding, we do not want to do. There are other indications which can also be considered, like if there is a pelvis or patient is very elderly or there have been multiple failures already at other centers, you may want to go for IVF directly. Maternal age is yet another factor, and there are studies which are Badavi, Marvi, and Steven, which I've listed down in the slide. And they all show that if the age is less than 35 years, success rates are higher. And once the age is more than 42, the success rates will fall below 2 to 3%. Male age is also very important, though many are fertile until very late in their age. Percentage-wise, the studies show that about 14% pregnancy can be achieved if the father is less than 35 years. It falls to less than 10% when the father is than 45 years. Also, miscarriage rates will be dramatically increased as there may be DNA fragmentation when the patient is elderly. So if there is oligosteatozoospermia, we are going to be aware and tell the patient that your chances are to the extent of 10 to 18%. But can we improve this? Can we give them a high percentage chance? This is what we are going to try and see with the tips that follow. This is a Cochrane database, and it has shown very clearly that IUI is superior to timed intercourse, no matter how close to the ovulation, both in natural and stimulated cycles. And therefore, IUI is very powerfully justified. And here there is the data which is coming from in 2000. It was a Cochrane review, and it said that the pregnancy rates can be up to 20 to 20% after 3 IUIs, which is very heartening. Now, how many cycles should we do? So the women will conceive within 3 cycles, but 6 cycles are advised. Cycle fecundity will decline by half to 2/3 after that. Nice fertility guidelines says can do up to 6 IUIs for patients because many patients cannot afford IVF and further treat with ART. So IUIs may be continued for up to 6 cycles without hesitation. Indications versus success rate is something that we need to know. That pregnancy rates are very indications when it is for IUI done for an ovulation, for mild to moderate male fertility and unexplained infertility. For some reasons, successes with endometriosis are relative. Various factors, of course, can be discussed as to why endometriosis causes reduction in implantation and pregnancy rates. What should be the number of follicles that would give us highest success? Since we do controlled ovarian stimulation and also we do natural cycle IUI, pregnancy per cycle have been discussed. And if there is one follicle, pregnancy rates as per Hutton et al. In 1999 are about 5.7% when there is one follicle, 13.6% when there are two, up to 16% when there are 3 follicles. However, when there are more follicles, and one should not IUI if there are more than 4 follicles, the pregnancy rates successively fall. Again, another data from Goven et al. And it says that the total motile semen count, if it is 10 to 20 million, success rates can be up to 18%. When it is 5 to 10 million, the success rates are about 5.6%, and it's to less than 3% once the count is lower. What about preparation methods? We will be taught many semen preparation methods when we attend any of the workshops on IUI. And this depends upon the semen characteristics. Commonly used method is, of course, the swim-up technique. And gradient technique should also be used, and it shows better quality. However, there is insufficient evidence to show that one particular technique is better than the other. And this was a Cochrane review in 2007. We could use swim-up method, albumin method, or a density gradient method. And whatever suits you is good. I again emphasize that the clinician who is going to do the IUI should take a drop of the prepared sample under the microscope and look at it for yourself, not leave it to the embryologist. With all due, it is the embryologist. Many clinics do not use embryologist. The local staff will prepare the semen sample. Times the prepared sample is perhaps poorer than the natural sample. So we need to be careful. We should give our patient the best. Advantages of sperm wash is that it's going to remove the prostaglandins, infections, antigenic factors, motile sperms, which are non-motile sperms, and leukocytes, which are there. Away. Timing is very important. You have to be closest to the ovulation. Remember, that the 12 hours are very fertile after the ovum has been released from the follicle. And therefore, timing insemination within 36 to 38 hours of post-HCG, presuming that ovulation is going to happen at that time, is very important. Should we do double insemination? We do not know. Many data show that it doesn't make a difference. But there are studies which say that you could do 2 inseminations one day apart, and it might improve the success rates. Now, LH surge versus HCG, I want all of you and the delegates to ponder on this point, and this is a very important point. When will the follicle actually rupture? You can time it in a non-antagonist cycle. I'm repeating it. If you have timed it after giving antagonist, it's a different issue. If the LH surge has not occurred and we give HCG as a trigger, it will end in ovulation between 36 to 37 hours, and that's the standard dictum. One patient has come to me with a 20 mm follicle, and LH surge has already occurred, and thereafter I am giving an HCG. Will the follicle rupture that same day, that day evening? I have called her for an IUI the next day, and therefore I may have missed the bus. This is a point to ponder. What is the period of abstinence which is important? Sexual abstinence of at least 2 days prior to IUI. Good. Pregnancy rate was highest when the abstinence was around 3 days. It was lowest when the abstinence was more than 10 days. And this is because of sperm senescence and maybe functional damage because of long days of an ejaculation. Whereas we talk about the type of catheter use, We should use what we are used to. Soft catheter is the best to use, and in my practice, we use a very soft catheter. There are others who say that even a top catheter is fine. Data reveals that there is not much difference, but a non-touch, gentle technique, soft catheter of your choice is vitally important. Should the patient take rest IUI? Maybe 10 to 15 minutes of immobilization is good enough, and it is shown to improve the success rate. Should the patient have intercourse after IUI? I once made a mistake of asking, can you have timed intercourse tomorrow, when we were actually doing it for erectile dysfunction? And he retorted, sir, if I could have intercourse, I would not have come to you. So one has to be very careful. It may not be very important to have intercourse the next day, not that it shows any change, but sure that if the patient has a lower sperm count, timed intercourse after IUI would be useful. Then there is a data about whether your IUI was easy or difficult, and it shows here, Gaussian et al. In human reproduction, that if it is easy, your success rates are a little higher. So there is no statistic difference here. One has to remember that if you have had a difficult IUI, then your pregnancy rates are lower. If you know that the cervix is difficult to negotiate, maybe a hysteroscopy pre is justified. However, a careful IUI is most justified. I think there is going to be topics controlled ovarian hyperstimulation on what to use during different procedures, so I won't elaborate on that. But we know that we want to increase the number of oocytes, which will increase steroid production and improve the chances of ovulation, to correct subtle hormonal changes, and of course, we have to manage the luteal phase support. So, will the super ovulation help? Oh, it surely does. In a natural cycle, the success rates are not so great. But when you do with CC with IUI, they are better. And with injectable, you can see on the screen, if you have used FSH with IUI, then the success rates are even up to 17%, which means that we are more careful when we are using these injectables. We know when the exact timing of ovulation is going to be. Therefore, perhaps the success rates are higher. Now, this is very important, GnRH antagonist, wherein if you start a 0.25 mg of GnRH antagonist when the follicle is 16 mm, add a little FSH to it if required, and then give your HCG trigger, you know that your ovulation is going to happen around 36 to 37 later. We can then time the IUI, and the success rates would surely be great. What is for triggering of ovulation? Most of us use 5 to 10,000 IU of HCG. We can also use, of course, 3 micrograms of recombinant HCG, or if the follicles are more, one could be using leuprolide acetate 1.5 mg, 2 doses, 12 hours apart. Timing of is vitally important, and it should be done in a CC cycle at 18 to 20, or at around 20 to 22 mm of the follicle size, when the endometrial thickness is more than 7 mm, and estradiol blood levels, though I don't do estradiol levels in most of my patients. Recommended in text is 200 picograms per ml for a 15 mm follicle each. When will you cancel an IUI cycle? If you have already given a trigger and the patient for some reason not turned up for more than 36 hours, it is pointless. If there are more follicles or more than 2 mm, irrespective of the E2 levels, avoid IUI. And of course, if the estradiol levels are high, you must make sure that you are doing this very carefully. Treat it like an embryo transfer, I am emphasizing. Use a Cusco speculum and negotiate the canal very gently. 95% of the times it will go in very easy. If you are not sure of accessing the cervix with Cusco, use same speculum. If required, hold the cervix very gently with a tenaculum or an Alice forceps. Have a partially filled urinary bladder, no ticks in the vagina at all. Atraumatically clean the cervix with a saline soap swab and aspirate the mucus atraumatically if required, and therefore your successes will be high. Pregnancy rates reported to be up to 15% when aspiration was done of cervical mucus, 9.9% when it was not done. Also, a slight traction on the cervix can straighten the uterocervical. Remember that it can set off uterine contractions, so do it only if necessary. Introduce the catheter carefully in a curved manner, but do not touch the fundus. Slowly inject about 0.3 to 0.5 ml of processed semen. It should not be injected, and allow the patient to rest for 15 minutes. Luteal phase support. Generally give vaginal pessaries up to 400 milligrams daily from the day or the second day of IUI, and we find success rates are higher because luteolysis very often will happen when you're using either a trigger stimulated cycle, the details of which I'm sure more of our speakers are going to talk on later on. What can be the complications? Sometimes you can get mild cramping, mild spotting, trauma, but be sure that there is no infection. Very rarely, patient will come with a vasovagal attack. Be careful that the patient does not leave the hospital within half an hour or 1 hour of your treatment. Sometimes allergens can happen, and if you are careless, you can land up with an ovarian hyperstimulation syndrome. Actually, IUI is a relative, non-invasive, more economical. Careful patient selection is extremely important. It is cost effective, especially for infertility and mild to moderate male factors. And failure of IUIs beyond 4 to 6 cycles is an indication to go ahead with ART. It's easy to perform. Training is easy. I feel and believe that we should train all our gynecologists in our surroundings from IUI, but train them carefully. There should not be mishaps. It is less invasive, it is minimal, quality control is possible, and costs are minimal too. And if you have a success with IUI, rest assured you have saved her the trouble of a lot of infertility treatment and problems in future. I thank everyone again, Tapisar, our chairpersons, and Dr. Reddy and Dr. Kalvaraj for calling me today on this August morning for this seminar. Thank you so much.
Thank you, sir. Thank you very much for the excellent presentation all about IUI. And you are well in time also. Thank you. Thank you very much. The questions will be at the end of the first session.
Good morning, everybody. It's always a pleasure to be part of this Tapisar activities. I thank Madam and Sir for this opportunity.
Sorry to interrupt, ma'am. Your voice is a little low. If you could just be a little louder. Thank you.
Okay, thank you. Thanks to Professor Sanjeev Reddy and Madam for this opportunity. Now we are going to have an exciting topic, that is stem cells in infertility. The research in stem cells has opened a lot of possibilities, huge possibilities in infertility, but how much of it is practically possible, how much of it can be practiced in the bedside. Now, to highlight on all the aspects of stem cells in infertility, I invite Dr. Sunita Tandulwarkar to give a talk. She is the director and founder medical advisor of Solo Stem Cells and Solo Stem Cell Infertility. And she is the head of the Department of Obs and Gynae, Ruby Hall Clinic, Pune, India. She is the chief of Ruby Hall IVF and Endoscopy Center. She is the chief advisor, DPU, IVF Endoscopy Center. She is the current chairperson of Maharashtra ISAR chapter. She is the president of IH 2019 to 20 period, and a second vice president of Indian Society of Assisted Reproduction, founder secretary of the Maharashtra chapter ISAR, vice president West Zone Foxy in 2017, and Foxy Infertility Committee chairperson 2011 to 2017. Advisor reviewer, Journal of Human Reproductive Sciences, and has received many national and international awards and has published many books and contributed chapters. Welcome you, ma'am, to this topic.
Thank you, ma'am. Thank you for your kind introduction. I congratulate the entire Tapisar doing excellent CMEs with various chapters. Dr. Sanjeeva Reddy is known for his academic excellence, and Madam, she is the brain with the beauty with us. We are all proud of this chapter and the people around. Can I start directly to my talk, this talk of stem cells with infertility? Thank you for giving me this beautiful topic. The stem cells is very close to my heart. I bring you greetings from my entire team of Stem Cell Center at Pune. Anytime you come to Pune, I'm happy to receive you all over here. Dear friends, these 20 minutes, I want you to work with the open mind. Mind is like a parachute. It doesn't work unless it's open. In infertility practice, one intractable problem we all face is a low ovarian reserve. And over for past, you can say, I have to take out this green bar somewhere.
It will go off, madam, on its own.
It's coming in my mind. At least for the past half century, clinicians have worked under the assumption that the entire reserve of the oocyte is fixed at birth, and human ovaries are not supposed to have the potential to receive any deposits. Only thing is there is a withdrawal which is possible, and it reaches to zero by mid-menopause. This classical ovarian reserve concept made a serious challenge in 2004. And then the debate started that oogenesis may be possible even in mammals and human beings. Specifically, oogonial stem cells have been reported to exist in the ovaries along with even adult humans, as with the mice and rats. This was a breakthrough, what you can call is a research, and then the stem cells, its role in infertility started. So will stem cells revolutionize the ART treatment? I think a lot of research publications are going on. Maybe a decade down, we will be in a better position to comment. As of now, this issue, whether the mammalian females possess such a population of renewable stem cells, remains unsettled, though promising results are seen in many studies. This topic of stem cell is quite complex. Even agreement on definitive approach to verify whether we can rescue the ovary is been elusive. Few investigators, this is important, that they found the expression of a germline markers even in the bone marrow derived cells. So even in the bone marrow derived stem cells, they found these germline markers, and they can renovate the ovary, or they can regenerate the oocytes. Interestingly, then the funda states that the bone marrow as well as peripheral blood transplantation can result in recovery of this oocyte production. And then the conclusion and the research started with the bone marrow or the PRP, whether we can use it as a source. And the stem cells got introduced in various therapies. Now, so what I mean by now is, up till now, we all were with the 5-6 decade, we're working that there is a fixed pool at the time of a birth and how it goes out and off till the adolescent age group until your menopause. That complete theory got revolutionized. So what are these stem cells? Body is made up of 200 different type of specialized cells. All these cells comes from the stem cells, and these stem cells are the cells which are not yet specialized, and once the specialization happens after reaching to the particular organ, it is called differentiation, then they become into the irreversible stage. So stem cells, why they are special? Because this is what happens. They renew, either they make more stem cells or they make a specialized. Once they go into this process, there is no reversing back. And we are not here to discuss any pluripotent or embryonic stem cells. So we all understand for a male or a female patients, haploid gametes are needed. And if they don't have the gametes, we all easily give them an option of donor gametes. At the same time, we need a healthy endometrium. And if the endometrium is damaged or if it is a refractory, we give a surrogacy as an option. And now we started thinking that these are the three main options in infertility. We can think about regenerating oligo or azoospermias, decreased reserve, or refractory endometrium. So now once we define the problem, we should know how to harness these stem cells. Today, I will be talking only about autologous bone marrow derived stem cells, which is a daycare procedure. The patient is caught in as a daycare. The pre-medication has been given, oxygen If you have a hyperbaric chamber, it is still fantastic. Some patient who can afford, we take them at Ruby Hall, because in Pune only at Ruby Hall we have a hyperbaric oxygen, and the most common site from where we retrieve is the posterior iliac bone, because very easily you can take out around 100 to 200 cc. With your knowledge increases, with your experience increases, initially we used to take out only 80 to 100 cc, but now we are going on with more, and those stem cells with the digitalized non-touch technique we take out. So from around 150 cc bone marrow, you retrieve around 15 to 16 cc, and then we can think of using them. So as early as 2006, this is a beautiful article which started discussing about the new strategies for the treatment of ovarian fertility and other degenerative diseases with the autologous ovarian stem cells. And then several publications a decade down on the human being, when they have performed that autologous stem cells can differentiate into the primordial cells, and they can become a functional haploid gametes, and the new hope in the treatment of ovarian fertility. Several researchers, along with the bone marrow, they have also documented ovarian stem cells even in the human beings over the period. So what happens is there is a considerable evidence. Now it is in existence, but let me tell you, still today, everywhere in the world, it is under research. It is not considered as an established therapy even today. So if you go on a clinical trial site, you will find many centers, they started their trial. Now, what is our experience at Solo Stem Cells? Frankly speaking, in 2015, when we entered in stem cells, we never thought of for infertility. It was for other degenerative conditions where we established that mainly to regenerate the kidneys and the pancreas for diabetic patients. And then we started thinking, if we have this facility, and then why not to start thinking about those publications which had come in 2015, they were in 2016, where we were also thinking, if the stem cell has entire 2015, I think I have studied like an MD student only about the stem cells, and they started thinking that if the stem cells are injected into the organ, they can recreate, why not to start thinking about it. And then we started thinking about ovarian regeneration, and we did world's first baby. We delivered a case report of under the care world's first baby. Till that time in 2017, when we declared this, there was in 2015 already the Egyptian people have come out with the world's first baby, but all the articles or all the studies have included below the 40 age group, and we had
Dr. Sunita Tandlwadkar. During an IVF journey spanning 5 years, we trialed stem cell therapy for ovarian rejuvenation and froze a fertilized embryo. This effort was followed by a successful embryo transfer and resulted in a healthy first pregnancy and live birth at the maternal age of 46. The birth of my child is no less than a miracle and has been made possible through the dedication, passion, and perseverance of my IVF team led by Dr. Sunita. On my part, I persisted with a positive spirit and took full care of my diet and fitness prior to and during the pregnancy.
What was important is the scientist from Dubai who came down, who believed in, and when she came to know I'm doing for a degenerative, I need to thank this, who was ready to be a part of it. So we started thinking that the stem cells may minimize the need for the egg donation program in these women. Then the several studies came with the platelet-rich plasma. Now it's important for all of us to know that the platelets have a tremendous role in our body. It eliminates the dead cells, the cellular debris. It is known to cause a tissue repair, and it also has the angiogenesis properties. Now, what this platelet signaling, Milu, if you see every month a lady ovulate, and the the follicle comes on the surface of the ovary and it ruptures and there is a regeneration and the wound healing happens. So how does this wound healing happens? If anytime you see the laparoscopy, you don't see the rupture signs unless it's a very recent of that month. So we all know that there is an interaction between the platelets and the plasma proteins, which causes fibrin clot formation, which is a reservoir of the growth factors. And these growth factors, they are discharged into the plasma through the platelets. So these platelets derive growth factors, but remember one very important thing, they are large, they are hydrophilic molecules with the 15 dalton, K dalton size. So they cannot penetrate through. They have to be injected into the organ for it to have its meaningful therapeutic option. And when one understood these properties, because in a dermatology, they have used the surface therapy or the subcutaneous therapies. What is important here, when we talk about it, we cannot have surface therapies, we need to do intraovarian. So if you inject these activated platelets, it releases several chemokines, the growth factors, VGF and all others, and these platelet derived growth factors are supposed to stimulate the ovarian stem cells and differentiate into the ovarian oocytes. So when you inject these ovarian stem cells, they recruit the precursor germ cells, the follicle, and the oocyte formation. So if activated platelets can do, because the ovary also can have its own intraovarian stem cells, and these after 2018, the publication started coming in, and the activation can be achieved with various other components. So when autologous activated PRP is injected, several early observations, they found it. This is the fourth patient study by the Scott Seals, released in 2018 February. That time we were doing our own ongoing project. I'll come to it. So they have included 4 patients. What's important is the age group 42. Transvaginally, they have put up 5 ml in each ovary, and they have recruited at least one blastocyst suitable for a cryopreservation. And they said, yes, one can think about this. Then in August 2018, this is a 3-case series, probably during the same size they were studying, because they have published not the blastocyst stage, but the early pregnancy and mid-trimester pregnancy stage. And they have found that there can be an activated platelet, one can think. Now, what is the concern if it is so simple? These investigators, they have presented many pieces of unclear puzzles. What is important is a PRP effect in the ovary, though in dermatology we know it so well, its effect in the ovary is just recent. It is less known than the stem cells. Second thing is, if the ovary stem cells are present, then what's the risk of activated PRP triggering tumorigenic or the malignant transformation of these? Instead of oocytes, can they give a malignant transformation, and that is very scary. But thus far, there are no adverse effect. Maybe 5 years or 10 years down the line, we may see untoward. But as of now, there are no untoward side effects reported in last 4 to 5 years. And one can think about instead of a donor oocyte option. What is our experience? What we thought differently was, if the PRP can be, even during this period, we were thinking about whether PRP along with the stem cells. So the PRP is known to make stem cells more effective, and they can also stimulate intraovarian. So we did combination of bone marrow stem cells along with PRP. Ours was the largest data of 20 cases. It has accepted now in publication. On 17 September 2019, we submitted, and probably the next journal you will see we have just finished our proofreading. So what did our aim and objective was? Safety as well as efficacy, because efficacy we saw it, but we wanted to see the safety along with the PRP in this one. It was an interventional pilot study of 20 cases from Jan 2017 to Jan 2019. We did this. And now it will be, we have found results in 65%, statistically significant. But it also leads me to tell why in 35% we did not found the result. Which are the phenotypes? Which are the ovarian molecules? What are the things? We obviously have done the genetic study. We ruled out any genetic or a fragile X syndrome. We ruled out tuberculosis or other factors which can cause damage, but still, and these were in our exclusion criteria, but still we did not got. So there is a lot of complex theories yet to undiscover. Only thing is, it's very easy that we got the result to say, but we need to wait and watch, and that is why still it is under research. But we have seen that there is, I personally felt the AFC count was very easily, in some women, very easily you see that. Many more pregnancies, we have even delivered our babies with this. But time is the answer, where we will come to know when ideally we should be doing a follow-up and when we should start stimulation and taking these patients. By now, we are thinking at 4 weeks, we can start safely to these patients, to the cohort. Now, once we think about oocytes and all, where else is the endometrium? Whether we can regenerate the endometrium. Bone marrow derived stem cells have been used, and 2006 the publication. I think 2011 our own Dr. Panchal and Dr. Nagori also published their case up to the first trimester. So quite innovative ways the stem cells have been studied for the bone marrow. And Carlos, we all know that this group has done a huge work and the follow-up of their patients. And 2020, this is another beautiful retrospective study which got into. According to them, yes, there is a paracrine mechanism to help the tissue regeneration with this CD133 bone marrow derived stem cells. What we did in our experience, we have not yet able to publish our data. They're very exciting. Now this baby is almost 2 years, which were the patients we thought about is being an endoscopic surgeon, we always felt we are regenerating. We are very easy with your endoscopic skill. Tuberculous cavity, you can make it, but there is all the fibrous tissue. You could nicely design the cavity, but is it important that can you maintain? We all know that only estrogens and progesterone, if you do after 6 weeks, you will find that this cavity is blocked again back. And these are the cases which we initially selected, and we decided why not, when we take out from the bone marrow, why not to go and think of regenerating and making this cavity. And it's a beautiful interview.
Hello, happy to share our feeling towards this novel therapy. My wife had adhesion in the uterus and was advised surrogacy. We came to Dr. Sunita, who did hysteroscopy in 2 sitting with stem cell therapy between and after second setting. What we noticed over the period of therapy that her menstrual flow had increased dramatically. For the first time when she started preparing lining for the frozen embryo, transfer team was not only happy for lining but also blood supply. Now she is in her 4th month of pregnancy and we are most happy couple.
What is important is initial period documentation with the video recording was important. Initially, see, there are no studies. After first symptom patient says is increase in the menstrual flow. And then we did 2 sittings with this stem cell therapy. There are 2 ways. Either you do the scrapping of the lining, you do this, or after the hysteroscopic procedure, immediately you do your. What is worry for me is whether we are regenerating the endometrium or whether we will be causing adenomyosis to this. Time is the one which will ensure and which will tell us whether the stem cell therapy really helps in regeneration or we are causing artificially induced adenomyosis to this patient. But the platelet-rich plasma, PRP, use of refractory in a refractory endometrium, the early publication in last 5-6 years, they were very good. Probably this was the first publication where they showed 5 cases, and we have done our own publication in 2017 with 68 cases. And I think by now in India, everyone is using PRP. We ourselves must have passed 500 plus cases, and it gives amazing results. We used to do even in refractory endometrium or where there is a sparse vascularity, and we found increasingly beautifully the vascularity. It is tremendous, but still I feel in some patient you can see 25 to 40 Doppler signals, while in some patient you get only 4 to 6. So there is a lot to learn even in this. Probably ours was the only study which has taken into account even up to the second trimesters, and the results were encouraging. Increase in the vascularity, and we have taken this patient up to the second trimester. You can tell me 2 minutes before I can stop anytime, but I think in PRP there are no side effects and one should adopt it for the refractory endometrium especially. For the male infertility, there are many studies in the patients of azoospermia. I don't have more than 4 cases personal studies, large ongoing datas. Many people, even the sperms, they have taken out from the somatic cells, though ethically it is not allowed, and turning stem cells into the sperm has become this. We have started taking our pilot study for a non-obstructive, but we could not progress after 1 year of 4 cases. We stopped our studies because we got in one patient sperm, other patient we could get it into the testicular, other 2 we did not. But unfortunately, we could not continue the study because there was no funding and ICMR was not giving any answer to it. So 2 cases with, you can say 50%, one need to do more than 100 cases, but you need a funding for this, because when you are not sure whether you will give a results to the patient, you can't just treat them like a guinea pig and we have to withhold our studies. But stem cells gives huge response in the erectile dysfunctions. Several studies, there are 35 published studies with the adipose tissues as well as autologous bone marrow, and everywhere they have found a fantastic results. So one can think about doing it into erectile dysfunction. Ethical concern across the globe is serious. You need to be ICMR registered for this, and ICMR in India doesn't give you very good response easily. We need to thank to the government who is thinking progressive, and for autologous, they have passed the legislation that it is no longer considered as a drug, and with DCGI you can move on. And we started now approaching the DCGI. On 25th March, our DCGI visit was due, but unfortunately the lockdown happened across the country and our DCGI visit is not yet done. Friends, after climbing a great hill, one only finds that there are many more hills to climb. We started as an obstetrician with the MD OBGYN. Then you enter in endoscopy, you realize many couple, you can't give just with the endoscopy the results. You start entering ART practice. Then you realize the ART pregnancies are high risk and they need a special care, and you start doing your high risk obstetrics. And then comes that ART still, you need to have a third party option unless you design something, and then you enter in stem cells. I don't know, maybe a decade down something more will come and we will start doing it. What is important is Choosing the path less chosen makes all the difference. You keep on thinking that you are still in a climbing phase. You never achieve till the end of your life. Thank you so much.
First-hand information from research. We will move on to the next topic for shortage of time. We will take the questions at the end.
We cannot hear Kanchana, your voice is not
Yes, sir.
audible.
My audio is open and I'm using my maximum volume. Is it okay, sir? Not audible?
Okay, you can introduce the next speaker?
Yes, sir. Very good morning. I thank my mentor, Dr. Sanjeev Reddy, for giving me this opportunity, and Kamala ma'am. I'm very honored to welcome Dr. Manish Banker for this talk. Sir will be enlightening us on current concepts in freeze-all and ART. Sir, Dr. Manish Banker is a medical director of Nova IVF Infertility, one of the largest group in India with 19 IVF clinics in 15 cities. He's been selected for the prestigious BC Roy Award 2017 by the Medical Council of India in 2017. He's a past president, Indian Society of Assisted Reproduction, 2012 to 2014. He's a chairman, Infertility Committee, Federation of Obstetrics and Gynecological Societies of India, between 2007 to 2010. He's member, the Draft Committee for ART Bill of India, ICMR, Ministry of Health, India, Editorial Board, Journal of Human Reproductive Sciences. He's a board member of the Poseidon Group. Over to you, sir.
Morning, everyone. And the outset, I would like to thank Tapisar and Zydus for inviting me to this very exciting webinar, looking at different concepts in ART practices. What I shall be speaking about is probably one of the most controversial areas in IVF today, and that is whether to freeze all embryos or do fresh transfers at all. Let us first understand what we have all chosen to become. And when we became doctors and we swore our Hippocrates oath, the first thing that we did was first do no harm. Whether we will do benefit or not is secondary, but at least we have all been sworn that we will not do any harm to our patient. Keeping this as the fundamental for my talk, let me take you through how this process has evolved. And I would like you to focus on two areas. One is a timeline, which I'm showing at the left end of my slide, which will tell you how the evidence has evolved right from the year 2005 till the current 2020. And depending on what evidence has come in, I will put a red, yellow, or a green mark to show whether it is in favor of a freeze-all strategy, is it equivocal, or is it against. So the first publication on this came in the year 2005 when the GnRH agonist trigger working group came out with this conclusion that the GnRHA triggering is a very valid alternative to HCG triggering, which results in elimination of ovarian hyperstimulation syndrome. So something which we had all sworn to, first do no harm. OHSS being a completely iatrogenic condition, we were on the right track. By giving an agonist trigger, we could eliminate this completely iatrogenic condition. But no sooner than this, in the same year, we had another publication which mentioned that in comparison to HCG, the agonist administration is associated with a significantly reduced likelihood of achieving a clinical pregnancy. So even though we are eliminating ovarian hyperstimulation syndrome, there is a significant reduction in the occurrence of clinical pregnancies. So the challenge with the agonist trigger was that we were not able to reduce, we were able to reduce the risk of OHSS, but we were unable to rescue the luteal phase. So we had the first equivocal finding here that this possibly does not work in all scenarios. In the year 2008, however, the belief was that is it still a controversy whether we should trigger with an agonist in patients who have ovarian hyperstimulation syndrome. But this path has already been finalized that giving the agonist trigger in a patient who is at risk of hyperstimulation is not controversial, and we will eliminate this for this high risk patients. And with this came the novel concept of segmentation by Professor Paul Devroy, and he devised the concept of an OHSS free clinic by segmenting the IVF cycle. What does this involve? This involves segmenting an IVF procedure into 3 separate steps. The first step, or the segment A, was ovarian stimulation, antagonist protocol, agonist trigger, and you avoid ovarian hyperstimulation. In segment B, we vitrify either the oocytes or the embryos, and then in the segment C, we transfer these embryos in a natural or a HRT protocol, completely eliminating ovarian stimulation. Now, why did this work? 3 basic reasons. One, we know that controlled ovarian stimulation results in endometrial advancements. When you stimulate the patient, the hormonal levels are pretty high, and this causes advancement of the endometrium. And this is seen if you do histological evaluation in an IVF cycle, something which has been published way back in 1997. We also know that if this advancement is more than 3 days, there are no pregnancies. This is looking at the advancement of the endometrium and looking at the pregnancy rate. And Ubaldi in 1997 showed that as the advancement increases and it crosses 3 days, pregnancy rates practically drop to 0. We also know that if the progesterone levels are elevated on the day of the trigger or the day of the progesterone start, the pregnancy rates drop significantly. And this was based on the study by Carlos Simmons group, where they did endometrial biopsy looking at the genes involved in the process of implantation. And they found that if the progesterone levels were above 1.5, the endometrium practically became non-receptive. It was also shown that these findings are more commoner in patients who are in the range of normal to high ovarian responders, multiple publications stressing on this fact. So this led to the evolution of the embryo frozen fever in the field of ART. Why did this succeed? 3 events which happened more or less around the same time. First and the foremost was significant improvement in the cryopreservation techniques with the introduction of vitrification, which gave nearly 99 to 100% survival rates. We moved almost exclusively from agonist to the antagonist protocol, which allowed us to trigger with an agonist. If we were still in the agonist era, this would not have been possible. And there was an increased use of genetic testing, which mandated that the embryos need be frozen, tested, and then transferred. So 3 parallel events again added to the need for doing freeze-all. But the question here is, why did it spread more and more, and why did it become more and more popular? This came in from because of 2 reasons. One, we have significant evidence that this kind of elective segmentation helps patients who are hyper responders, because you want to prevent ovarian hyperstimulation syndrome. It helps patients who have elevated progesterone because the endometrium is non-receptive. And it also helps patients where there is an endometrial issue, either asynchrony or an advancement. But these indications kept on adding. We had newer indications added to this. We moved into the era of embryo pooling in lower responders, increasing use of PGT, and increasing awareness regarding social freezing, which necessitated segmenting the cycle. So the indications which require segmentation kept on increasing. But it is important to understand what Pete Boss said a long time back, that hunches are usually wrong, and hunches of expert authorities in the fields are also usually wrong. We actually need evidence, and let us see what is the evidence behind this practice. So it all started with this first evidence, and this was in the year 2013. The first systemic review and meta-analysis published by, remember this name, Matthews Rock in Fertility Sterility 2013. He did an analysis of 3 trials, 633 women, comparing fresh with frozen embryo transfer. And what he concluded was significant higher implantation, clinical and ongoing pregnancy rates by performing an FET. And the reason behind this, he mentioned, was an improvement in the embryo endometrium synchrony. These were the 3 studies included in this trial. The paper by Alpha Union, highest number of patients, 374, and 2 papers by Shapiro, 137 and 122. But the question is this the true picture? And let us see what happened later on. These were the 3 studies included in this meta-analysis. If you look at the 3 studies, only 1 paper is on normal responder, and that is a study of just 137 patients, 67 and 70 patients on each arm. The other 2 are on high responders. The first paper by Alpha Union was actually retracted because the journal which published it found serious flaws in this particular study. So this publication got retracted, and this whole meta-analysis was also considered not valid. So something which set the ball rolling is itself was found to be non-scientific, and that entire meta-analysis has been withdrawn. So we have the first red dot in this. Till now, it was all green or yellow. Then came this paper in New England Journal of Medicine, 2016, fresh versus frozen embryo transfer from a group in China, again in patients with polycystic ovarian syndrome, 1,500 patients, and they found that the pregnancy rates was significantly higher in patients following an all-freeze strategy versus a fresh strategy. So they concluded that among patients with infertility and PCOS, elective frozen embryo transfer was associated with a higher pregnancy rate. One more green circle. The first Cochrane analysis came, however, in 2017, looking at all the published evidence till date, and let us see what this meta-analysis showed. Clinical pregnancy rate per woman, fresh versus frozen embryo transfer, no evidence of difference. Ongoing pregnancy rates per woman, fresh versus frozen embryo transfer, no evidence of difference. Live birth rates, fresh versus frozen embryo transfers, 4 studies, no evidence of difference. So we have the first data showing fresh and frozen are equal, and this is from no less than from the Cochrane library. 1 year later, 2018, we have 2 landmark papers in the New England Journal of Medicine, one from Vietnam, one from China, looking at patients without PCOS and in normal ovulatory women. Large studies, 780 patients, more than 2,000. And what did both these studies show? Both the studies concluded that in women without PCOS, normal ovulation, there was no difference in the live birth rate in a fresh versus frozen embryo transfer. So we suddenly have equivocal data coming in that both are equally good. And when we thought that the controversy was almost solved, we have this Lancet paper of 2019, again coming out of China, looking at live birth rates from a fresh frozen single blastocyst transfer. And this concluded that doing a freeze-all gives a higher singleton live birth rate compared to a fresh embryo transfer. So we have one more green, 2019. So let us pause here and see what evidence do we have till now. There is no doubt that it is safer because it practically eliminates ovarian hyperstimulation syndrome. As far as its efficacy, live birth rate, ongoing pregnancy rate, or clinical pregnancy rates, all data till date suggests that it is either as good as equal or frozen is slightly better. So there is no evidence till now suggesting that doing a freeze-all is doing any harm. However, it is important that what we have focused on till now is prevention of ovarian hyperstimulation, and we have focused on improvement in pregnancy and live birth rates. But what about these other 4 factors? Time to achieve a pregnancy, cost to achieve a pregnancy, and what we are have sworn to follow. That is, first, do no harm. What about adverse pregnancy events and adverse perinatal outcomes? What are the results of fresh versus frozen on all these four parameters? Time to pregnancy, obviously you cannot have a study, but it has to be more by at least one cycle because you are deferring a fresh transfer. Cost of pregnancy, again, no evidence, but it is common sense that if you do elective cryopreservation, the cost will be higher because there will be additional expenses associated with freezing, warming, extra workload, and the endometrial priming and monitoring before FET. So there is no doubt that doing elective freezing increases the cost of a pregnancy and it increases the time to pregnancy. But what about the other two? And we had the first publication on this in 2017, looking at 16,000 births from ART, fresh versus frozen embryo transfer, self oocytes. And this study showed that there is a significant increased risk of preeclampsia, with the odds ratio being 2.1 if you do a frozen embryo transfer versus the fresh embryo transfer. The question is, why does doing a frozen embryo transfer increase the risk of preeclampsia? And this comes from this very beautiful publication from China, which has looked at the knockdown of this PTN and its incidence or linkage to preeclampsia. So what this paper showed that the risk of preeclampsia was increased following vitrification thawed embryo because of the knockdown effect on the PTN. So it is the vitrification process which is possibly causing a knockdown of this molecule, leading to the increase in the incidence of preeclampsia. It is not the HRT protocol, but it is possibly linked to vitrification per se. We then had the Cochrane review looking at pregnancy complications, and this concluded that there were more pregnancy complications in freeze-all group, and these complications included ectopic pregnancy, fetal growth disorders, preterm births, pregnancy-induced hypertension, and HELP syndrome. So not only was the incidence of preeclampsia includes, many other pregnancy complications were higher. This publication in 2018 then focused on perinatal outcomes, and what this concluded that the risk of a large for gestational baby was increased 1.5-fold when you do a frozen versus fresh, and the incidence of macrosomia increased 1.7 times in a frozen versus a fresh embryo transfer. We have two very large publications later on, all in the year 2019, looking at health outcomes to children who have been born after a fresh versus a frozen embryo transfer. And this paper looked at nearly 14,500 babies who were born in a 10-year period, either following a fresh embryo transfer or following a frozen embryo transfer. And they have compared all the infant outcomes and the maternal health outcomes. And what it concluded that infants born through a frozen embryo transfer have a greater odds of developing infectious diseases, respiratory diseases, and neurological conditions than those who have been born following a fresh embryo transfer. And they advise that this risk should be considered in the decision-making process when you select fresh versus a frozen embryo transfer. We also have a very large study looking at 3,500 IVF cycles published November 2019. And they have looked at all types of cycles, fresh, frozen. So first fresh, segmented, not segmented, second attempt, third attempt. And what this study showed that after 30 years after introduction of cryopreservation, elective freezing of all embryos for patients, if it is used in an unselected manner, without heed to laboratory expertise or looking at the patient profile, it can potentially compromise the cumulative live birth rates of an IVF cycle. And this finding support that it should be restricted to patients in whom there is a clear clinical need. So it should not be offered to all patients at one go. So why this confusion? From so many green dots, we suddenly have so many red dots here. Why is this difference? And like for everything in medicine, you cannot have one shoe fits all. And this is very beautifully shown from this analysis from the SART registry, that the freeze-all of embryos is beneficial in high responders, patients who have 15 plus oocytes. But if you look at normal responders, or if you look at patients who are poor responders, 1 to 5 oocytes or 6 to 14 oocytes, freeze-all policy does not help the patient. So it again comes to selecting the right patient for the right procedure. And this is the meta-analysis published fairly late, which shows that there is a higher probability of live birth only in high responders, but not in normal responders. And hence, it should be the preferred option only for high responders, but in the normal responders, this strategy should not be applied. And we come back then to where it all started. Remember the author, Matthews Rowe, who published the first meta-analysis favoring a freeze-all strategy, March 2019. Same clinician, first author. Currently, no clinical data to support the widespread use of freeze-all strategy for all patients. It should be given to patients who are at risk or when you have to perform PGT. But for all other indications, such as an implantation failure, advanced maternal age, endometriosis, there is still lack of evidence to support an all-freeze strategy. And why is this? This is beautifully demonstrated in this SWOT analysis that freeze-all has a lot of strengths, primarily reducing the risk of ovarian hyperstimulation syndrome and possibly certain better obstetric outcomes, but it has weaknesses that there are very few RCTs. Gives an opportunity in terms of scheduling because we can plan the frozen embryo transfers, but it is associated with a lot of threats. So based on this SWOT analysis, paucity of data in terms of financial burden and complete lack of evidence, it should yet not be advocated to all populations. So the million-dollar question in front of us is, fresh IVF cycles increases the risk of small for gestational age. Frozen increases the risk of large for gestational age. Which of these two is worse? Remember, our first motto is do no harm. By preventing the risk of ovarian hyperstimulation in the mother, are we putting the mother at a higher risk of preeclampsia or are we putting the child at a higher risk? Which of this is worse? So where do we stand today? Pregnancy rates, high responders, high P4, freeze-all is good. Normal responders, poor responders, possibly equivocal. It reduces the risk of ovarian hyperstimulation, but it increases the risk of preeclampsia. It decreases the risk of small for gestational age, but it increases the risk of large for gestational age. Neonatal complications in terms of respiratory disorders, neurological conditions are higher with frozen as compared to the fresh embryo transfer. So what do we need today is, we need more long-term studies on the effect of vitrification, both maternal and fetal, and we need large meta-analysis which show consistent findings that freeze-all is superior to a fresh transfer in all categories of patients. Till then, maybe freeze-all freeze everyone, but it is not for all, at least not yet. I thank you all for a very patient hearing, and let us discuss this very controversial topic at the end of all the sessions. Thank you very much.
Thank you, sir.
Now the session is open for question and answers. Okay. You can check both question and answers thing, and also chat box also some questions are there, you can ask.
Okay. So shall I start? The question is for Dr. Kedarnath.
Yes, yes.
From Dr. Geeta Raj. What is the rationale behind using Luprate trigger 2 doses 12 hours apart in IUI cycle?
Kedar, you are there?
Yes, sir.
Okay.
Sometimes you will have 2 to 3 dominant follicles and many small follicles, say about 10 to 8 to 10 size. These ones which ultimately lead to OHSS, and therefore one has to be very careful. If you are out, there only you used a GnRH analog as a trigger, 1.5 12 hours apart, and you will get a release of the follicle, but you will not land in OHSS. Routinely, we would like to use HCG. But in such a situation, if you use HCG and when you have two dominant follicles and 7-8 small follicles, you might land into a large number of follicles at the time of IUI, and that might make you cancel and or put the patient at the risk of OHSS. So it's important to be careful.
The next question is, why 2 doses of leuprate for trigger? Again, it is answered by Dr. Millen. The next one is, how long LH surge will last? Today, if LH test is positive, means when can I do IUI after 24 hours?
Basically, physiologically, if there is an LH surge, you might land a patient within 12 hours. It is not necessarily 36 hours. And this is the physiological data which many times found, if you read your Sperov properly, that if the patient gets an LH surge permanently, you might find an ovulation happening within 12 hours. That was why that slide was important, and I would like everyone to comment, even Dr. Manish Bankar and all, that if a patient has walked into my clinic, the follicle size is 2 mm, I'm going to give her an HCG and call her for an IUI the next day. What if the LH happened yesterday already, and today evening she ovulates? I'm going to do the IUI the next day. This is a factor that we need to remember. Maybe I might even call her next day morning, but it's a dicey situation. And we don't routinely do urine test for LH surge and then decide to give an HCG and then call the patient. So these are factors that we need to remember. We might be getting failures because we have missed the initial timing of ovulation altogether.
Kedar, I agree with you. I think this is a very good question. When you are doing a routine IUI, we don't look for LH measurement. So there will be some patients who will have an LH surge and will ovulate before your IUI. It is because of all these factors, the success rate of IUI is what it is. The only way to prevent this is either to track LH or to give antagonist to everyone. But then the cost-benefit ratio is not in favor of antagonist to everyone. But to answer the earlier question on the agonist trigger, I have a slightly different point of view. If you look at this whole evolution of field concept, it came from the fact that it helps in preventing the occurrence of ovarian hyperstimulation when you give an agonist trigger. So you save the patient from the risk of the OHSS. But the immediate side effect of this is that it kills the corpus luteum and it leads to a dramatic reduction in the pregnancy rate. Now, in a patient of IUI, first, if the patient is at risk of hyperstimulation, why even proceed with it? IUI is a simpler process, it is safer to cancel it. And second, by giving an agonist trigger, if in an IVF cycle the pregnancy rate drops so drastically, imagine IUI with a pregnancy rate of 14-15%, how much that pregnancy rate would drop. So on the one hand, you are not gaining anything. You are reducing the already low pregnancy rate of IUI, and you are unnecessarily putting the patient at risk. So to me, there is no role of an agonist trigger in an IUI. If the patient is at risk, cancel the cycle. I would never give an agonist trigger in an IUI.
Nice point, Manish. I also agree with you, and I don't put it in practice. However, when giving a talk on a national forum, I had to put into question all the factors which are mentioned in the textbooks. That these are the options which are available, and per se, I don't use agonist trigger at all in my practice, and that's a good take-home message to take. That feel that there is going to be OHSS, you might as well not do the trigger at all, and we are confident that you have only 2 to 3 dominant follicles. Go ahead with an HCG.
And
I think that's a fantastic.
Again, one more point. If the patient is at risk of OHSS, it means she has a large number of follicles. If by chance, after an agonist trigger, she becomes pregnant, you are putting her at a risk of multiple pregnancies.
It's true.
Also,
Believe me,
Kedar, important thing
important message I think this your talk has passed on is first IUI after 24 hours. If you see all the publication or even the Cochrane, 36 hours is the IUI, and they have proved that single versus double makes no difference. But in clinical practice, what happens in our day-to-day practice is we don't keep on tracing the LH for the patients. And we just, with the follicle size, we go give our trigger. So endogenous LH search might have started, and that's why in our practice, first IUI doing at 24 hours, but before IUI, by using the disposable cover on the vaginal probe, have a habit of checking the follicle. If the follicle is not ruptured yet, and if it is the male subfertility which you have thought of, you can think of doing the another IUI 24 hours later. That's what I do in my practice.
There is a very interesting recent publication which has compared doing an IUI at the time of HCG trigger versus 36 hours later. So it was HCG injection and IUI, HCG injection and IUI 36 hours later, prospective randomized, pregnancy rate was the same. This is a very
question.
Very
There is one more point that I wanted to make, which I put on the slide, and that is we as clinicians are very busy. Patient has collected a sample at 8 a.m. in the morning. It has been prepared and ready at 11 o'clock after liquefaction and stacking. It should be transferred into the patient within half an hour or 45 minutes. Don't wait for 1 o'clock. After you have finished a C-section or an OM pickup and then do the IUI. This service.
There is a question to Dr.
So there are
Sunita.
two questions to Dr. Manish.
Yes.
Manish Banker, sir. The first question is, the incidence of childhood cancers are reported being more after FET cycles. What is your opinion on that?
I'm not yet aware of this publication. Let me check. The childhood cancer data, I don't know, but the other complications which I mentioned, I'm aware of this. This I need to, I'm not aware of this.
So another
Just one
question is,
question.
sir, one more question for you, for Dr. Manish Banker is, how will you manage an endometrial advancement in a fresh embryo transfer?
First of all, there is no way of checking whether the endometrium is advanced in a fresh cycle. The only measure that you have is measuring the serum progesterone. And if on the day of the trigger, the serum progesterone is more than 1.5, then we convert this into an elective wall freeze. If it is below 1.5, then we have to assume that the endometrium is fine and we proceed with the fresh embryo transfer.
One question to Dr. Sunita. This is about minimum limit of AMH or the maximum age for ovarian stem cell therapy, and how long after stem cell therapy the stimulation to be started.
See, which woman will need the oocytes or the need for this is obviously the elderly age group. I have taken 45 age group, and that's why I showed even in the PRP, the main age group was 42, plus minus 16 months or something like that. Second, your question is, so age is not, even if the 30 years, in my 20 cases of a pilot study, you will find that even 30-year lady, the 80% of the women are nowadays, because of, we don't know, lifestyle or the pollution or the, we are finding decreasing ovarian reserve at younger generation. So
I think we are exceeding our time.
Thank you, ma'am. Thank you.
Just one hint from Madam I wanted. Madam, Dr. Sunita, how much PRP and at what date? How much PRP is and at what date to be introduced into the uterine cavity?
okay, the PRP usually 0.5 ml to 0.9 ml. Now, what date is not, when you are doing, usually on day 7, the first sonography is done, you don't conclude that the lining is not going to prepare in this cycle. So on day, usually between day 12 to 14, we call for the second sonography. And that time, if I find that the vascularity is sparse or the lining is not, but they don't want to cancel the cycle,
we are exceeding time.
That time.
I'm sorry to interfere. I think we are exceeding our time. I'm going to introduce. I'm very, very sorry. Is it okay, moderators? Is it okay?
It's okay.
Because the questions can be kept to the end if you want to talk. Okay? Is it okay, Dr. Sanjeev Reddy? I'm introducing, is it only introduce the next group of moderators? Dr. Ashok Kumar, Dr. S. Ashok Kumar, consultant fertility specialist, andrologist and gynec laparoscopic surgeon, diploma in reproductive medicine, Kiel University, Germany, trained in infertility microsurgery, Weill Cornell University, USA, fellowship in reproductive medicine, Kraft Hospital, Kerala, fellowship in advanced laparoscopy robotic oncology, Galaxy, Pune, former unit department, King's Medical College, Tamil Nadu, former associate professor, College of Medical Science, Nepal, managing committee member of Tamil Nadu State Chapter IAGE, faculty for training in advanced laparoscopy course, Johnson & Johnson and Bloom Fertility Center. That's all I can see here. Next speaker, Dr. Aruna Ashok. Sir? Dr. Aruna Ashok, MS, OG and DNB, OG Fertility Consultant, Clinical Director of A4 Fertility Center and Hospital. Education experience, MBBS Kilpauk, MS, OG, Jigma, Pondicherry, Fertility Training and Reproductive Medicine Division of Sri Ramchandra Medical Institute, 12 years of experience in the field of fertility. Awards achieved: Gold Medical, MBBS OB/GYN, Jigma Institute of Gold Medical, Medal in Obstetric and Gynecology, Pondicherry University Gold Medal in Obstetric and Gynecology, Toxic Quiz winner, speaker in international conferences, and presented papers, guide for fellowship course in infertility for 3 years. Special his interest of endoscopic surgeries, improving the success rates in IVF failure couples. Next speaker, Kavita Gautam, MS, OG, DRM, FA, COG, leading clinician and director, Bloom Fertility and Healthcare, director, Bloom Birthing Center, executive committee member of Tamil Nadu chapter of IAGE, South Zone Coordinator for FOXI Infertility Committee, South Zone Coordinator for FOXI Sexual Medicine Committee. Welcome all the speakers. Now I hand over the session to the moderators. Thank you so much.
Yeah, thank you very much, ma'am. First of all, let me thank Dr. Kamala Selvaraj, ma'am, Dr. Sanjeev Reddy and the Tapisar group for giving this opportunity. So our next speaker is Dr. Sanjay Makwana, who will be talking about male infertility and azoospermia, what a gynecologist must know. Now, we all know that, male infertility is on boom, and I think now it's high time that gynecologists should know what should be done for male infertility. So to introduce Dr. Sanjay, he has finished his diploma in pelvic endoscopic surgery from Germany and France. He has also done fellowship in IVF from Belgium, the ex-executive member from IFS, ISAR. He is a chairperson for Rajasthan ISAR chapter. He has published almost 13 papers and he has got 5 textbook chapters. He has been invited as faculty member at various national conferences and he has trained more than 250 doctors in ART and endoscopic surgery. He is working in the field of ART and endoscopy since 1995. So with this vast experience, I would hand over to Dr. Sanjay, sir. Welcome, sir.
I'm audible? Dr. Ashok?
Yes, sir.
Thank you, Chairperson, Dr. Ashok, Dr. Kavita, and Dr. Aruna. And first of all, my thanks goes to Dr. Kamala Selvaraj and Dr. Sanjeeva Reddy for giving me this opportunity to interact with all of you. I'll be talking on about the male infertility, what gynecologists should know. Let the slide start. Greetings from Jodhpur, Rajasthan. Male infertility, we all understand that it comprises almost 15 to 25% of the cases dedicated only to the male. And if we combine the factor male and female responsible through the male factor, is almost 50% of the cases responsible. So it's a big number, and we must understand it should be taken care by the primary clinician or a gynecologist, those who are seeing the couple. Abnormal semen quality is a significant factor in a male, and we all understand that the male generally defer the consultation because they perceive the subfertility or infertility as a threat to their masculinity. So it's very important that the first clinician must always assess them. The idiopathic oligoasthenoteratozoospermia is the commonest cause, and that is represented through the reduced count of the functional spermatozoa. And that can be because of the genital tract infection. There are the variety of the diseases or abnormalities, systemic disorders. The external factor may be the lifestyle or drug uses, or the combination of all of these, and they may lead to the reduced count of the functional spermatozoa. Very rarely it is caused by the deficiency of the endocrine system. The most common nomenclature which we come across is the agiospermia. Let's start with this. Agiospermia, which is defined as the complete absence of sperm from the ejaculate. We must differentiate for another term that is known as the aspermia, where there is a complete absence of seminal fluid emission upon the ejaculation. There's one more condition we should be aware of, and that is the severe oligospermia. And to differentiate between the agiospermia and the severe oligospermia, one must have the palate, and that should be taken for examination under the microscope at least 2 times before that saying that this is truly a agiospermic patient. How to differentiate the variety of the agiospermia? Basically, we can say it's the testicular, pre-testicular, and the post-testicular type of agiospermia. And the testicular is the most common cause, almost involves 60% of the cases. Post-testicular is almost 40%, rest of the cases, and they belongs to the ejaculatory dysfunction or obstruction of the sperm delivery to the urethral meatus. Few of them belongs to the pre-testicular, that is known as endocrine abnormalities, or they are because of the secondary testicular failure. What is important as a gynecologist or a clinician for us is what are the cases which is correctable. The pre-testicular and the post-testicular abnormalities that causes agiospermia are frequently correctable. The testicular disorders are generally irreversible except because of the varicocele. If there is a suppression of spermatogenesis, that can be recovered. There is another way to differentiate between the agiospermia is based on the semen examination. If the volume is less than 1 ml and the pH is less than 7, most of the time we say it's obstructive agiospermia, and the volume is more than 1 ml or the pH more than 7, comfortably we can say, okay, yes, it's a non-obstructive agiospermia, though the exceptions are always there. So what are the endocrine estimations required in these patients? Initial endocrine evaluation should include the measurement of serum testosterone and the FSH. The normal FSH, of course, does not exclude the testicular cause. And as well as, this is important to understand that it will not help in prognostication of the sperm retrieval. If the value of FSH is more than double, definitely is the spermatogenic factor or the testicular factor, and the prognosis is going to be poor. Additional hormonal assay in the case of agiospermia routinely not required, but the serum prolactin, especially in the cases of hypogonadism or sexual dysfunctions, can be taken into considerations. Severe obesity or gynecomastia, the other like the SCG or estrogen can even be considered. Testosterone is a key male hormone, but generally the peripheral blood will not reflect the true values of the testosterone. It is the free testosterone that should be taken into consideration because the level at the testes is generally very high. If the levels are low, then they may represent a decreased sperm production at the testicular level. But the first step for us is to confirm whether it's a truly agiospermia or not. And before that, we must confirm that ejaculate is truly an ejaculation of semen or not. Most of the time, patient may deposit a simple urine in the small amount. So not every ejaculate is a semen. That is very important. A post-ejaculatory urinalysis should be performed in the patient with the ejaculatory volume of less than 1 ml. That is except in the patient of bilateral basal agenesis or clinical sign of hypogonadism. And we must exclude the retrograde ejaculation, especially if there is a pelvis injury history in the past or urethral injuries in the past, then definitely the injury to the posterior urethral wall may be responsible for the aspermia or agiospermia, and that may be because of the retrograde ejaculation. What are the basic questions when we start proceeding for these patients? First, whether it is obstructive or non-obstructive agiospermia. If it is obstructive agiospermia, whether it is operable, and if it is operable, can we get the success or not? Surgery, it should be compared by the PSA. See, If it is a non-obstructive agiospermia, is there any treatment, or can we get the sperm for the ICSI? There's one important chemical in the semen, and that is very important. You can say the decision maker for us, and that is the fructose, which is secreted from the prostate and seminal vesicle. If the fructose is absent, especially in the cases of obstructive agiospermia, it may be because of the congenital absence of the vas or ejaculatory duct obstruction. If the fructose is present, most of the time we can say it's a primary testicular failure or obstructive agiospermia close to the testes. That is a block at the epididymis or the proximal part of the vas. This is the ring where you can understand if the obstruction in this area, close to the seminal vesicle or the prostatic area, then definitely the fructose will be absent. If the obstruction is close to the testes or epididymis, then the chances of having the fructose present and the volume is normal. The role of transscrotal or rectal sonography in routine, practically I say there is no role in a male infertility because all the findings, they can be elicited clinically, like the diagnosing the varicocele, spermatoceles, absence of the vas, or epididymal induration or testicular masses. All they can be by the simple clinical examination can be confirmed. The Doppler may diagnose the minimal varicocele, but then it has no clinical significance for us. So if we require for a documentation, then ultrasound, a color Doppler for confirmation of varicocele can be. Otherwise, the routine use of ultrasound in a male has a less significance. Genetic screening. In the case of agiospermia, there are three most common genetic factors. One is the cystic fibrosis gene mutation associated with the congenital absence of vas. The chromosome abnormalities resulting in an impaired testicular function that is found in the 10 to 15% of the males, or Y chromosome microdeletion that is associated with the impaired spermatogenic impairment. Karyotyping and the Y chromosome microdeletion analysis should be offered to the male who has non-obstructive agiospermia or a severe oligospermia prior to performing ICSI. Genetic testing for the CFTR mutation in a female partner should be offered before proceeding with the treatment that utilizes the sperm of male with the congenital absence of vas. So guideline is when the vasal agenesis or testicular atrophy are not present and the semen volume and the FSH are the key factor in determining the etiology of agiospermia. Agiospermia with a normal volume, the proximal obstruction or abnormality of spermatogenesis must be looked for. Agiospermia with the low semen volume and the normal size testes may have the ejaculatory dysfunction or the distal obstruction. Additional semen parameter that can be helpful in determining the presence of ejaculatory duct obstruction are seminal pH and the fructose. Since the seminal vesicle secretions are alkaline and contain the fructose, transrectal sonography here becomes more reliable. When the patient is having the normal ejaculate volume, the marked elevation of FSH becomes a diagnostic of abnormal spermatogenesis. The role of testicular biopsy here, because it may be needed to establish the normal spermatogenesis, but it does not provide the accurate prognostic information as whether or not the sperm will be found in the future sperm retrieval attempts. So, but it's better prognosticator than the FSH in the testicular volume. In addition, the presence or absence of sperm in the diagnostic testicular biopsy specimen does not absolutely predict whether sperms are present elsewhere or in the opposite testes. Therefore, the testicular biopsy is not necessary to either establish a diagnosis or to gain clinical useful prognostic information for a patient with a clinical finding consistent with the diagnosis of non-obstructive agiospermia. So blindly sending the patient for the testicular biopsy should be avoided. Conversely, the patient who have a normal serum FSH should undergo a diagnostic testicular biopsy, as a normal semen FSH level does not assure the presence of normal spermatogenesis, and this can be done in conjugation with exploratory surgery or when we are planning for the cryofreezing of the sperms. So unnecessary biopsy procedure can be avoided. In case of non-obstructive agiospermia, sperm found in the biopsy, then ICSI either with the same time when the pickup and stimulation is going, or a frozen ICSI can be planned. If the sperms are not found, then take multiple tubules under the microscope and they must be explored. Performing multiple biopsies, if the sperms are present, then they can be frozen or can be used in the the same cycle, or otherwise they can be used as a cryofrozen samples. The surgical sperm retrieval techniques of sperm retrieval and the micromanipulation to assist the fertilization have been two of the most exciting development in the field of male infertility treatment in the last 30 years. There are the various techniques through which the sperms can be retrieved in the agiospermic patients. There are the percutaneous sperm epididymal aspiration, or maybe the microepididymal sperm aspiration. Especially these are the cases of obstructive agiospermia. If it is failed, then the testicular aspiration can be done, especially in the cases of genital absence of the vas, and the success in these cases is as high as 50%. The testicular tissue extraction or micro-teaser can be used in the case of non-obstructive agiospermia, and as high as 67% of the success can be achieved. But this must be counseled to the patient before embarking over these procedures. How to predict a successful sperm retrieval in non-obstructive agiospermia? The previous biopsy, by far the best, which has a sensitivity as high as 86%, serum FSH, testicular size, testicular volume, they are the weak indicator, does not prognosticate or does not assure us of retrieval procedure. Testosterone, again, a weak indicator. There are a few new markers, especially the seminal plasma proteins, but still we have to wait for them. The role of microsurgery for the obstructive agiospermia, especially we all know that vasoepididymostomy or vasovasostomy are the procedures. If they are done with a good hand, they can give us a good outcome. But in the cases of congenital absence of vas or obstruction because of the tuberculosis, should be treated with the sperm retrieval procedure. Surgery should not be planned for. Vasoepididymostomy or VEA give as high as the 50% patency rate and the pregnancy rate as high as 25%, whereas the VVA gives the pregnancy rate as high as 52% with the patency rate with the microsurgical procedure as high as 95% case.
Sorry to disturb. You have 2 more minutes to go, sir.
Okay, I'll rush slightly. I'll just finish here the reconstruction versus ICSI. Coming to the semen, the cornerstone for diagnosis of male infertility, WHO has given to the last guideline in 2010. We must follow that. There are the various interpretations of the semen examination depending on the sperm count, morphology, and the motility. As per that, we can classify them. Though we must understand that these parameters, however, are poorly standardized, subjective, and not powerful predictor of the fertility. The better is the total motile sperm count. Based on that, we can have the pre-wash sample. If it is more than 5 million, then the IUI can be planned. If it is between 1 to 5 million IVF and less than 1 million total motile sperm count, then the ICSI should be advised for. Oxidative stress, all we know that plays an important role. Increase in the reactive oxygen species can lead to the sperm damage, and that can lead to the infertility in the male. Male accessory gland infection is another important aspect, but the antibiotic most of the time doesn't provide increased probability of the conception. They may improve the sperm quality. These are the leukocytospenia or agglutination. They all indicate the presence of the infection either through the urogenital system, and that is responsible for the poor motility and the poor outcome of the procedure, whether it is ICSI or a IUI. Idiopathic oligoteratozoospermia, a common cause of male infertility. 30 to 40% of cases are considered idiopathic, may be explained by the endocrine disruption as a result of the environmental pollution, reactive oxygen species, or genetic abnormalities. What is important for us to know that artificial insemination, that is IUI, can improve if the teratozoospermia is between 3 to 4% of the normal sperms. In the case, if it is the severe, the moderate, that is 1 to 2% of the teratozoospermia, normal sperm can be found, and the IVF should be advised for. If it is the severe teratozoospermia, there is normal sperm count is less than 1%, then ICSI should be advised to them. In most of these cases where the ICSI is planned, the IMC is the better choice to select the morphological normal sperms. As far as the hormone examination is concerned, already we have talked about in agiospermia. FSH has some role to play here, but doesn't improve the overall understanding about the low counts. Advanced sperm tests, that is the DNA fragmentation or the oxidative stress test, are not routinely required, but in case of repeated IUI or IVF failure, spontaneous abortions, previous low fertilization, varicocele with the normozoospermia, then they should be asked for. There are the various strategies where we can reduce the DNA fragmentation index, maybe the short abstinence, oral antioxidant therapy. If the varicocele is present, then varicocelectomy. In the case of IUI, the density gradient or swimmer procedures can be done. In case of IVF, then MC, PXC, or the cell sorting can be used to reduce the DNA fragmentation. Varicocele, we all know, is a very important correctable cause in the male. Is associated with the progressive testicular damage. Varicocelectomy can reverse the sperm DNA damage. Surgery for the subclinical varicocele should not be recommended. The younger the age, greater sperm density, large varicocele with the testicular volume not reduced to less than 20% or low or normal FSH, then the recovery with the surgery is good.
I'm really sorry, Dr. Sanjay.
I understand. I'll just finish in the last two slides.
Yes, I feel miserable. Okay.
Yes, I'll
sorry.
just go to the last two, how to optimize the sperms. There are the three ways: the lifestyle factor, treatment option, and laboratory factor. The lifestyle factor, we all know, obesity, smoking has an important role. Alcohol, caffeine, we are not sure about. The same with the psychological factor and the environmental factor, we are not sure how much they affect the sperms. Treatment options are medical, they are very limited. Antioxidants can reduce the reactive oxygen species production. Sperm vitalizers, they can improve the sperm mortality. Nutritional supplement, we are not sure about their outcome. Same with the antibiotics. If there is an infection present, they can be of help. Surgery, we already talked of. As far as the hormonal therapy in the male is concerned, is controversial because normal gonadotropic patient doesn't require a supplementation either with the anti-estrogens or aromatase inhibitors. Gonadotropins or androgens can be needed in the cases of hypogonadotropic hypogonadism. As far as the laboratory factors are concerned, abstinence of course improves the outcome. Collection in the media, if it is known that there is agglutination or highly viscous sample, split ejaculation in case of the sperm antibodies, if they are present, then can be used. Collection at home definitely improves the total picture. MC or PXC or cell sorting can be used in the cases when there is a severe teratozoospermia. We must evaluate. We must remember always evaluate a patient as a couple. Perform the women workup simultaneously to the man. Just because one member of couple is abnormal doesn't mean that other one is going to be normal. That warrant a full workup. Thank you. I try to finish as quick as possible. Thanks a lot.
I think moderator just say two words and so we keep
Dr.
up.
Aruna, you can introduce Dr.
We all
Amit
are
Patki.
eager to hear Dr.
Yeah,
Hello.
thank you, sir. Thank you for teacher Sanjeev Reddy sir and Kamala
That's
madam
all
for
not
giving.
necessary. Aruna, just
Because
introduce.
we want Dr. Durashaw to listen to his speech. Therefore, we have to keep it to time. Don't have to introduce everybody, just the name and that's it. Okay?
Yeah, thank you. Thank you, madam. I think we are late by half an hour and we are starting at 11:30. So our talk should be over by 11:50, I suppose. I think we can take the time, madam.
You can,
Yeah.
you can project. We'll cut the discussion for the time. You can wait for the end because Durashaw has to talk. And you can project a slide that people can read for a minute.
Yeah. Okay. So, yeah.
Do as you please. Come on.
Yeah, this is we are delighted to invite Dr. Amit Patki to have a talk on PCOS, how we reach the crossroads in management. He's a medical director, Fertility Associates Mumbai. He is honorary associate professor of KJ Somaya Medical College and Hospital. He's a consultant in Kar, Hinduja and Surya Hospitals Mumbai. He is a governing council member ICOG, vice president ISAR 2021, general secretary MSR 2018 to 20, chair West Zone RCOG 2015 to 19, president MOGS 2014 to 15. He has almost 35 publications in national and international journals, and he has authored almost 50 book chapters and editor of 3 books. He has been he is having 2 international patents in infertility and stem cell research. He is also a TED speaker. Over to you, sir. We are curious to listen to your speech.
Thank you very much. And at the onset, I would like to thank Dr. Kamala Selvaraj and Dr. Sanjeeva Reddy for giving me this opportunity to be part of your Tapisar
Your slides.
Monday. Yeah. Okay, so without wasting much time, I'm going to start my talk. There's a very old Voltaire saying which says the art of medicine is to amuse the patient while nature cures the disease. And this cannot be more true in PCOS, where we know that if the patient takes care of her lifestyle problems, she can help herself more than any other doctor. There's a very old Zen saying which says we teach best of things we want to learn more. And this is very true for me because we all know that the incidence of PCOS has dramatically increased over the last decade in our practice. So viewers, have we reached the crossroads in management of PCOS? We know there's a large amount of treatment modalities that are available for PCOS, and how do we choose these modalities is what is the main question today. What exactly is PCOS? This is a mystery to most people, even to the experts of so-called PCOS problem, because in the 1990 NIH-NICHD conference, not a single PCOS criteria was endorsed by more than 64% of the so-called experts. And at the end of 2 days, they came to a conclusion that possibly insulin resistance, increased LH-FSH ratio, and polycystic ovaries on sonography could be the possible criteria. This was followed by the Rotterdam Escheri ASRM consensus of 2013, where this consents to say that any two of the three, oligo or anovulation, clinical or biochemical hyperandrogenemia, and PCOS on sonography could be considered as diagnostic. But Michael Crichton, who is a medical critic, said that there is nothing like consensus in science. If it's consensus, it isn't science. And if it is science, it isn't consensus. And consensus is evoked only in conditions where science is not solid enough. And this is precisely what was happening. We were missing a large number of PCOS patients or overdiagnosing some people with PCOS based on this Rotterdam criteria. And now I think things have become a little better with this 2018 International Evidence-Based Guidelines for Management and Assessment of PCOS, which is a joint initiative of Monash University with ASRM and Escheri. But is PCOS so relevant to our practice in India? It is, because it is one of the most common endocrine dysfunctions in the fertile group, occurs in almost 18%, but in my mind, it is more than 25% of all the patients that I see for infertility. And it doesn't stop there. It is associated with abnormal GTTs, increased risk of type 2 diabetes and hypertension, and fibrinolytic and lipid derangements in the latter years, called as metabolic X syndrome. So we have to continue to keep our patients under surveillance even after they've finished their childbearing. Now, PCOS can be divided into four main phenotypes. The classic ones are the ones with hyperandrogenemia, chronic anovulation, and polycystic ovaries on sonography, which contribute to almost 60% of all PCOS. But the other 30% group are the ones with hyperandrogenemia and polycystic ovaries, but have perfectly ovulatory cycles, and by far and large may not come to us for infertility treatment. Having said that, 70% of patients have anovulation, and besides PCOS, the other causes could be ovarian failure, which is another big group that we are seeing at a very young age with reduced antral follicle counts, autoimmune causes, and other iatrogenic causes. The other hormonal abnormalities that are related with anovulation is hypothyroidism, most often subclinical hypothyroidism, where you have your TSH levels in the slightly higher range of normality, adrenal disorders, Cushing's, and congenital adrenal tumors. So when you have young girls who come with PCOS, the treatment of choice should be the birth control pills or the combined oral contraceptive pills, because one, it helps them to regularize their cycle. It will definitely reduce the anti-androgenic properties that are exhibited in these young adolescent girls, like acne, pimples, and hyperandrogenemia, and will also reduce the chronically elevated LH levels. You have the other group of patients who want to maintain regular cycles but do not want to take contraceptive pills. And in such women, you could offer them cyclical progestogens for 10 days, because this will ensure that they do not get endometrial hyperplasia, which is a preponderant cause for later endometrial cancers and other things. It will regularize their periods, at the same time giving them an opportunity to maintain their fertility. But in the vast majority that come to us with irregular menses and infertility, and ovulation is the cause, and they need some oral ovulogens as a first line of treatment. Clomiphene citrate has been used, has been the gold standard for last so many years, not going to get into the pharmacological actions, but nevertheless to say it is a competitively inhibitor of E2, and with its negative feedback will increase the FSH, will increase the recruitment, and will give us a multifollicular response if started earlier in the cycle. So it can be used for ovulation induction, ovulation augmentation, and in a controlled stimulation in ART cycles. Drawbacks are that although ovulation rates are high, pregnancy rates can be low because of its peripheral anti-estrogenic action, has a long half-life, and should not be ideally used back to back. So what is the other drug that we can use? The other drug is letrozole, which is now strongly established as the drug of choice for PCO patients. Competitive inhibitor, highly selective, more often will give you a monofollicular response. The anti-estrogenic actions are very short-lived and hence can be used back to back. And when you compare both of them, you find that letrozole gives you a much better pregnancy rates than clomiphene, and that is what it is. Letrozole should be the first drug of choice in PCO patients. But we need a better drug. We need a drug which can be given orally without high risk, like both CC and letrozole can give you hyperstimulations, and requiring minimal monitoring. Now, such a drug will be a drug which will work on the insulin resistance, because this is a key pathogenesis. 80% of obese patients and 30 to 40% of even the lean patients will have insulin resistance. Insulin resistance giving you rise to hyperinsulinemia, which will indirectly give you hyperandrogenemia, and then will give you the range of problems that PCOS can exhibit. So what is the role of insulin sensitizers? It will increase the sensitivity of insulin towards the receptor, thereby decreasing hyperinsulinemia. We have myoinositols and D-chiroinositols. The myoinositol is present in high concentration in the ovary, in the follicular fluid, and it is known to improve ovulatory functions. On the other hand, D-chiroinositol has no effect on the ovarian level. High concentration in glycogen storage tissues such as liver, muscles, and fat, and this will rapidly reduce peripheral hyperinsulinemia. And both together, the myoinositols and the D-chiroinositols in the right proportion is the drug that we should be given, because peripheral tissues will be active with D-chiro, and the ovary where myoinositol is used. Myoinositol will improve your oocyte quality. But we have to be careful that high doses of D-chiro can be detrimental, can be toxic for the ovarian physiology, and hence it is to be given in a ratio of 40:1. This will help us to have effective myo-inositol and D-chiro-inositols to rapidly get the hyperinsulinemia down and decrease the insulin resistance. But prior to this, what was the doses that we were using for myo? Most often the doses are going to be twice, which is 12 hourly. And the suggestive uses are, in young patients, you could use myo-inositols. In the lean PCOs, you could use myo. The combination of myo and D-chiro is specific for the obese PCOs, for the infertile PCOs. And again, myo with metformin is for the severe PCO patients with insulin resistance, and again in the metabolic X syndrome patients, the slightly elderly patients. So can myo be combined with metformin? Yes, metformin has been used for last 2 decades in PCOs. It suppresses appetite, enhances weight loss. The extended use of it is much better tolerated. You start with a low dose, you increase to up to 1.5 to 2 grams per day. We know that metformin, along with lifestyle, will give you almost a 30% change in the menstrual cyclicity, reduction in BMI, and spontaneous ovulation. It's known to reduce the testosterone levels and reduce the hyperinsulinemia. Previously, we were giving metformin even in early pregnancy, thinking it reduces the miscarriage rates. But now we know that we need to continue to give it in early pregnancy, not because it reduces early miscarriages, but is known to increase your live birth rates afterwards. So metformin needs to be combined with a hypocaloric diet, and both together, metformin in a dose of 850 given twice a day, when combined with a hypocaloric diet, will definitely reduce your visceral, your abdominal fat, serum insulin, testosterone, and leptin concentrations. We know that metformin alone gives you an increase in ovulation as compared to placebo, but may not give you statistically increased rates in pregnancy. But when metformin is combined with clomiphene or with letrose, we know it gives you a statistically increased ovulation rates and early pregnancy rates as compared to clomiphene. So clomiphene resistant patients could be put on metformin for a few months to start the clomiphene again. We know that metformin is very good. It may improve the odds of miscarriage, as I said before, but it is known to give you a better live birth rate. Now, as compared to gonadotrophins, obviously metformin CC combination not as effective, but gonadotrophins can be offered to only a small percentage of patients, those who can be very well monitored and those who can maybe afford to take gonadotrophin. So the next step would be gonadotrophins, because they obviously give you a higher ovulation rates, a higher pregnancy rates, but will also give you a higher multiple order pregnancies, and hence should be reserved for patients who can be monitored properly besides their financial ability to get and buy these medicines. We also know now metformin can be given in patients in whom hyperinsulinemia is not present. Even in those patients, it works well. So measuring hyperinsulinemia is not done routinely in PCO patients. And metformin can be used in patients where you cannot give the birth control pill, maybe because of the risk of coagulopathy, or in the lean PCO patients. There is a very good Indian study which has compared metformin and myo-inositols versus metformin alone. And this study is over 120 patients in both groups. And it has very well shown that there is an increase in fertility, in a better improvement in hormonal parameters when metformin and myo-inositol is combined together. and can be used in the severe PCO patients, but understand that lifestyle disorders is always there. Ovarian drilling is a very good procedure in patients with failed medical treatment. We know it works very well, but overzealous drilling has its fallouts, can cause adhesions. We also have seen patients coming with ovarian failures. Gonadotrophins, as I said, when oral ovulogens do not work better, can be combined with the oral ovulogens. Recombinant is better in PCO patients because recombinant FSH will not give you an additional LH. In PCO patients, you often have the persistently high LH or the premature LH surge, in whom antagonist use is very good, even in the IUI cycles, but not in every IUI cycle for PCO patients. So what is the eye opener? The eye opener is that your high miscarriage rates are related to BMI. So weight loss, typically at least 10% weight loss, is very, very important. It is not associated with any egg quality or embryo quality or any other.
Excuse me, we have 3 more minutes to go.
Yes, I'll finish it in the time. Management of an ovulatory PCOS is lifestyle, and lifestyle again, weight reduction, at least 10%, we say. Now, for weight reduction in the very obese patients with BMI more than 34, the use of anti-obesity drugs can be considered. The drug of choice is orlistat because it is the only drug which is FDA approved. However, adverse effects are steatorrhea, flatulence, which is associated. So maybe a low-fat diet is what they need. And the very obese patients need bariatric surgery, indicated in patients with BMI more than 40 with co-medical morbidities. They lose around 40-50 kgs over 2 years, and they take their treatment only 1.5 to 2 years after their bariatric surgery is done, because you need to replace the micronutrients and the vitamins in these patients. The surgery of choice is the gastric banding, the proximal gastric bypass, and the sleeve gastrectomy are the other surgeries that can be done. But the advantage of the band is that it can be released in pregnancy, and you do not come across IUGR that you come across in other bariatric surgery patients who get pregnant after their bariatric surgery. We have managed around 3 dozen patients of ART after bariatric surgery, done 18 to 24 months after bariatric surgery with very good outcomes. What are the newer pharmacological agents of importance or that can be easily used are the statins, the vitamin D supplements, and the caribos. OHSS prevention is something that I think we all should know about. You can monitor your PCO patients with AMH. We know that in very high responders, the antagonist treatment is the drug of choice. So to summarize, lifestyle modifications, pharmacological therapy interventions, surgical interventions only in drilling or in the very obese as bariatric surgeries, and don't forget to supervise your patients even after they finish childbearing to prevent metabolic syndromes. The newer guidelines of 2018 endorsed Rotterdam criteria say that sonography is not essential in the adolescent PCOS. Management is multidisciplinary, self-empowerment and education of the patient. COC is the first drug of pharmacological choice. Metformin can be added. Letrose is the first drug of choice for infertility. Gonadotrophin, the second line, and IVF treatment, the third line. Thank you very much for a patient hearing. And I think it is very important that you talk to your patient, you counsel your patient, and you supervise your patient to prevent metabolic X syndrome. Thank you very much to Tapisar for giving me this opportunity to reach your audience. Thank you.
Thank you, sir.
On the dot.
Yeah.
Hello everyone. I'm here to introduce the Rockstar speaker who doesn't require an introduction at all, Dr. Rishma Dilon Pai, the President of Mumbai Obstetrics and Gynecology Society, President Indian Society for Assisted Reproduction between 18 and 90, and President Indian Association of Gynecologist Endoscopists 2018 and 19. Over to you, Rishma Pai ma'am, because your topic is very important and we would like to hear more about what you speak.
Thank you. I'll just share my screen. Give me just another minute. All right, can you all see my screen now?
Yes, ma'am.
Thank you. Thank you all for this wonderful invitation. Extremely interesting session going on. And my subject again is going to be extremely controversial. And let me begin by saying to you that even the most complex problem is resolved in the end. Because if there's a question, there is also an answer. And today, we really are seeking answers to this extremely complex problem of recurrent implantation failure. And we're going to be focusing on the maternal factors causing this particular problem. The Barker hypothesis said that the womb may be more important than the home. In humans, it's the uterus and its endometrial mucosa that are the anatomical functional prerequisites for continuing the species. And they are also the limiting factor for improving the efficacy of human reproduction. Successful implantation, we all know, requires a good embryo, appropriately timed and arranged endometrial and wonderful crosstalk between the two, which results in success. But this receptivity is characterized by very finite and time-sensitive window implantation. And many factors influence that: endocrine, paracrine, autocrine factors. And all of these are important for implantation. So starting with a very basic definition, as you know, recurrent implantation failure is the failure of pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles in women under age 40, or you can consider it when 10 embryos are transferred in fresh or frozen cycles. And you'll be surprised to know that more than 80% of transferred embryos fail to be implanted. And 10% of women seeking IVF will be completely frustrated with this problem of recurrent implantation failure. So obviously, the first thing that we will be looking at will be the uterine and adnexal pathologies. These are quite gross. If there's a myoma pressing the uterus, you remove it. Hydrosalping is, need to be either clipped or removed. If there is a massive septum, remove it prior to doing your procedure. And adenomyosis and endometriosis both have a very negative impact on pregnancy, and we know that. So these are the gross factors which in all patients of RIF, we will treat before we go forward. But we know that our main focus is on the endometrium. And so when we look at the thickness, we look at the triple line pattern, and we look at the blood flow, we get a fairly good idea about how the endometrium looks. So with the help of sonography, hysteroscopy, or a biopsy, very, very rarely an MRI, we can evaluate the endometrium. So remember, all of us look at the endometrium when we're doing the transfer. But even when you're doing a frozen embryo transfer, this nice study tells us that the endometrium thickness at the time of the actual pickup during the fresh pickup cycle is important. So during the pickup, if your endometrial thickness was good, your chances of pregnancy are much, much higher, 84%, compared to the success rate, which is much lower if the endometrium was thin during the pickup. So even if you do your transfer 6 months later, that factor was important. And remember that, to evaluate that at that time. Hysteroscopy today is a very, very important tool. And most of us have seen that pregnancy rate is significantly higher if you have a hysteroscopy done, some pathology like a polyp or an adhesion or some infection is picked up and it's treated, your outcomes will be significantly better. One thing we all usually overlook, and that is endometritis. And today there's a huge amount of focus on this endometritis. So even hysteroscopy, it's as accurate as immunohistochemistry for evaluation of endometritis. And so just a hysteroscopy, of course, do a biopsy, but accurate assessment of endometritis. And in our country, with tuberculosis, you know, it's very, very important. And we have a reasonably good new test, the expert assay, which helps further in evaluating tuberculosis, because we know that we really didn't have any good test for tuberculosis testing. So what really now are the newer things to evaluate the endometrium? Look at the implantation window, extremely important. Look at the histopathology for growth disorders, inflammatory lesions, retained products of conception. There are many candidate markers for endometrial assessment once we go deeper and deeper. And very often we find that there is a glandular developmental arrest. And when we see the presence of mouse ascites Golgi and cyclin E, these actually help us to evaluate this lag between the glands and the stroma. And of course, in clinical practice today, we have many new tests. We have the endometrial receptivity assay, the function test, and the inflammatory marker test. And we'll just touch upon these briefly. So the viable tests, the commercially available test that we have first is the endometrial receptivity assay, or the ERA test, which actually identifies errors in dating. There's a synchrony between the embryo and the endometrium. So when you biopsy it exactly on LH+7, or when you start progesterone in a frozen thaw cycle on day 5 of progesterone, you can actually evaluate if the endometrium is out of sync. We also have to identify errors in function. So the endometrial function test takes 2 biopsies, one on day 15 and on day 25, and evaluates for development as well as for pathology. And there's another test called the receptivity DX test, which actually looks for the expression of the B-cell lymphoma 6 marker. And this is actually a marker for endometriosis, but is a good marker. And if we pick it up, we can actually improve outcomes. And we'll talk about this just a bit later. So remember that it's not always that the window is delayed or is early. It's not only asynchronous. Very often, the window of implantation is pathological. And in this particular study, they found that when you actually stratify these endometriums transcriptomically, you could find that only 18% had a displaced window of opportunity, whereas 53% had both displaced and pathological window. So when you do an ERA test and put back your embryos, it may not work. So you have to select the patients who have a displaced window, and only in them the personalized embryo transfer will work, because with pathological window, it will not work. So this is what I was talking about, the B-cell lymphoma 6 testing, because this is expressed in the endometrium and it may be related to infertility. Overexpression of this gene repressor has been linked to progesterone resistance, and it has been shown that there's a live birth following IVF of 11% only versus 58% in patients who have this with and without this elevated BCL6 testing. So we may treat these patients with GnRH agonist, or if there's endometriosis, we should treat that, and you'll see that there's a significant improvement. So new markers are coming in. This you can see is a very, very recent report from 2020. Another very important focus, and again, this report has come out just last month, and that is the focus on vaginal microbiota and the associated metabolomes. So it has been found when you do a gene sequencing of the vaginal microbiota that the vaginal lactobacillus showed a significantly positive correlation with pregnancy. And so if you can actually check this, you can improve the outcomes by improving the vaginal microbiota with either with antibiotics or with probiotics. Another very recent study released just earlier this month is about the presence of the placenta-specific protein 1 in these patients of recurrent implantation failure. And it was found that there was a higher placenta-specific protein 1 in infertile women with RIF, suggesting that could have a negative impact on implantation. And so this can be actually a serum marker, which we can do. So many new tests are coming in, helping us to solve this very, very difficult problem. Because I have realized that the more I live, the more I learn. And the more I learn, the more I realize that the less I know. And we truly know very less in this very complicated problem. So when we have done so many tests, how do we actually treat? The simplest thing to do is really a laparoscopy, because with this, whenever you find endometriosis or a fibroid or a hydrosalpinx, you can treat it. And many people become pregnant on their own just following a good laparoscopy and adhesiolysis or some treatment. Endometriosis and adenomyosis, very, very negative impact, particularly adenomyosis on pregnancy outcomes. So always look at that and treat it prior to attempting your IVF cycle again. So many of the European guidelines have said that remove your fibroids, remove septum, do adhesiolysis, and of course, remove polyps. And by doing these interventions, you'll improve your outcomes. Just hysteroscopy, you have seen, even without a pathology, just doing a hysteroscopy by itself actually helps improve implantation. And you can see that pregnancy rates have improved just by doing a hysteroscopy. Maybe it's the scratching, maybe it's the dilatation, we don't know what happens, but it helps to improve outcomes. Thin endometrium has been a very, very difficult problem, and everything has been tried to improve it, such as aspirin, arginine, sildenafil. Lots of things have been tried, but does anything really work? And is the thickness of the endometrium very, very important? Cochrane review came out just a while ago, which said that vasodilators, which are used left, right, and center for patients with thin endometrium, actually are not proven to be effective. So there is insufficient evidence to improve the live birth rates with vasodilators. So at the moment, not recommended. What is recommended, however, is a very simple intervention. GnRH analog and aromatase inhibitor letrozole 5 mg daily continuously for 2 months is actually seen to improve live birth rate. So that's an intervention you can easily do. Another simple intervention again is the use of growth hormone. And it has been found that the growth hormone not only acts on the egg and improves its quality, but it has a positive effect even on the endometrial receptivity, particularly in these patients with RIF. Again, another simple intervention, atosiban, the use of that seems to have a positive effect on implantation. So these are simple interventions which you can do. I spoke earlier about endometritis, and this has become huge, and you'll see lots and lots of publications even this year on chronic endometritis. So immunohistochemistry you must do, try to find out chronic endometritis, and you can treat it of course with antibiotics, but there are also important things like doing an intrauterine infusion of antibiotic in certain failure cases, and you'll be able to see good outcomes. So here, antibiotic intrauterine infusion has been tried when normal antibiotics have failed, and we've got better outcomes in patients with endometritis. But HCG, simple, inexpensive, all of us have it. Intrauterine infusion of HCG has been shown to improve the chemokine-triggered endometrial and embryonic dialogue, and it intensifies angiogenesis, immune response, and might actually help pregnancy outcomes. So very simple intervention, infuse HCG. GCSF, again, all of us have a lot of experience with GCSF, whether it's given subcutaneously, whether it's infused in the endometrial cavity, there seems to be better outcomes with the use of GCSF. And this particular technique, again, last year, the review came out that they were giving PRP. So PRP was given 0.7 ml intrauterine, and GCSF was given subcutaneously right from the time PRP was started, and it was given every week. And this combination primer, this is called, significantly improved outcomes in patients. So very simple interventions, which many of us can do. PRP, lots and lots of papers on that, seem to help. Intrauterine infusion of PRP 2 to 3 times from 10th day of the menstrual cycle seems to improve outcomes again. So patient's own sample, no outside material being used, and we can get improvement in the outcomes. So, of course, stem cells, the peripheral blood mononuclear stem cells, again, when they're activated with HCG and used, seem to improve outcomes. So again, lots of studies on stem cells, helping improve endometrial thickness, helping improve implantation. What has come into a bit of a debate is scratching. You know that for the last 2-3 years, everybody was doing endometrial scratching as a magical method to improve implantation. But now the latest studies are saying it is not guaranteed, or it's not clear whether endometrial scratching really improves the live birth rates or not. So right now, there are no clear guidelines on endometrial scratching. This debate on immunological factors goes on and on and on, because we know that cytokines and natural killer cells have important roles in the success of implantation. And because of that, people have tried glucocorticoids, steroids, left, right, and center. But the ASRM guidelines have come out and they do not recommend the use of glucocorticoids to improve implantation. Yet they say that in very well selected cases, maybe we have some role for immunomodulators such as IVIG, intralipids, but none of these things are really recommended at the present moment. So you can see these are all latest studies. Even today, there is no clarity on these immunological therapies. What does seem to work maybe is getting an ideal BMI, reducing smoking, reducing stress, because stress hormone actually reduces psychological, immunological, and other stressors, and it may make the body not perfect for pregnancy. And even things like transcutaneous electric acupuncture has seemed to work in certain cases. So sometimes when the major therapies don't work, alternate therapies may work. And obviously, if everything else fails, as long as the government allows us, we may have to resort to surrogacy. And of course, many of us with many IVF failures, miscarriages repeated, do eventually resort to surrogacy. Now, of course, we have an option of uterine transplant as well. And last year, it was reported already detailed studies of 45 cases of uterine transplant with 9 live births. And I'm sure between then and now, there must be so many more which have happened, including our Indian uterine transplant success and baby delivered. So that becomes a very difficult,
just
very
2 more minutes to go.
Yes, I'll finish on time. Thank you. So, of course, today, this option is there, very risky, very difficult, and I hope absolutely last resort for our patients, but this option is there for our patients today. And so we know repeated implantation failure, huge problem, very stressful for patients, emotionally, psychologically, financially, and also the doctor is very frustrated. But at the end of the day, there is some hope. And what is this hope? This study gives us some hope. That what is the prognosis for a live birth after unexplained infertility? It was seen that the cumulative incidence of live birth, when you follow up the patient for 5 years after recurrent implantation failure, 49% of them became pregnant, either with IVF or more of them, even from natural conception. So even though you've tried and failed, don't give up. Overall, there is a reasonable prognosis of a live birth in these patients who've had recurrent implantation failures. Of course, half of them will still not succeed, but many of them will become spontaneously pregnant. And so in the future, we're looking to many new things. Some of them have already started in our clinical practice. There's a lot of focus on the endometrial dome because we know that the bacterial communities have a huge impact on reproductive success. So maybe simple things like probiotic treatment will help correct endometrial biome. So we have today the EMA test, the endometrial microbiome metagenomic analysis. It's available today commercially. That might help us analyze the myome. We have ALICE test, which is actually the analysis of infectious chronic endometritis, and you can actually detect endometritis and treat it specifically. There is a lot of new regenerative medicine coming in, endometrial regeneration in even severe cases of Asherman syndrome with autologous cell therapy, with CD33, bone marrow-derived stem cells. And of course, finally, a magical thing like a bioengineered artificial uterus with the use of autologous cells from putative recipients. And believe me, they've been able to grow animals in bioengineered artificial uterus. And if they can do that, I think humans may not be very far behind. So let me end by saying that success is the good fortune that comes from aspiration, desperation, perspiration, and inspiration. And for these patients of recurrent implantation failure, I think we need all of these to help us get through to the other side and achieve success. Thank you. Thank you very much.
Thank you, Rishma ma'am. It was a wonderful talk, crisp on time. Thank you so much for sharing that wonderful knowledge.
Yeah.
I think we go to the last session now. And I'm going to cut short the introduction since we're running late. Dr. Sharmila from Grand Medical College, Mumbai, Chairman of Clinical Research, President of Menstrual Hygiene Management, Joint Treasurer of Indian Fertility Society, Director of Aditi Hospital and Parvati Ayovu Fertility Center, Trichy, Consultant in Southern Railway Hospital, Trichy, awarded Sri Mohandal Desai Prize, and also past Secretary of Trichy and OG Society, organizing Secretary of Yuva Foxy South Zone 2013, has won 5 trophies for Foxy, Secretary of Trichy and OG, HMS Champion Foxy 2013, and also won the Pandit Prize for Women Empowerment, awarded Dr. Meru Vansutia Prize for Committee, Foxy 2018, editor of Handbook of RPL and 2019 IICOG Campus, June 2020. And what is PI? I don't know. First, Foxy Multi-Center Mother Study on Ovarian Reserve 2019. I welcome you, Dr. Sharmila.
Thank you, ma'am. Thank you, Kamala, madam.
Dr. Nirmala Vijay Kumar, Consultant of Reproductive Medicine, Queen's Fertility Center, Tirunelveli, TM, MBBS, Tirunelveli Medical College, MGR Medical University, Tamil Nadu, 1992 to 1998. MD C. Ramchandra Medical College, 1999 to 2002, MRCOG 2005, Royal College of Obstetrics and Gynecology, UK, Assistant Professor of Chettinad Hospitals and Research Institute, 2006 to 8, Consultant Reproductive Medicine, 10 to 12, Meenakshi Mission Hospital, Madurai, Consultant Reproductive Medicine, 2012 onwards, Queen's Fertility Center, Tirunelveli. Welcome you, Dr. Dr. Sharmila. KRT Manual Hospital, Manu Hospital, Simar Coimbatore, Indian University Hospital, and Warwickshire, UK, under Dr. Richard Kennedy. Invited speaker and panelists in fertility CME and conferences, conducting CME in Coimbatore every year, 2012 on infertility and fetal medicine, member of ISA, India, and also IFS and FPSI, Joint Secretary, Coimbatore Chapter of Tapisar, IFS, Tamil Nadu Chapter. I welcome you, Dr. Aarti.
Thank you, ma'am. The first talk will be by Professor Pratap Kumar, and it's a great privilege that I get the opportunity to introduce Sir. Sir is the HOD, Department of OBGYN and the Division of Reproductive Medicine, Kasturiba Medical College, Manipal. He's been the Vice President of Foxy in 1999. He's been the President of the Karnataka State ONG Societies in 2011 and 12. He's been the member of the Task Force of Human Developmental and Research Disease Biology Department of Biotechnology, New Delhi. Sir has been the member of the Project Review Group in ICMR, Delhi. He's been awarded the Fertivision 2018 Leading Lights in Field of Reproductive Medicine in 2018 by the Indian Fertility Society. He's been awarded the Dr. Durusha Lifetime Achievement Award in 2017 by ISAR. He's got almost 300 publications and 800 presentations to his credit. He's edited 10 textbooks and has contributed to several chapters and several books. And the topic he's going to talk is a very apt topic of why is the biological clock clicking in a woman and what are the remedies. And we know it's a difficult topic, but Sir will always give us crisp messages. Waiting for that. Thank you, sir.
Thank you very much, Sharmila, for introduction. Thanks, Kamala and Sanjeev, for inviting me. My topic for today is aging ovary. Why is the biological clock clicking? Are there any remedies? I bring greetings from Manipal University, from Karnataka State. Now, we know the mechanism of aging is not very clear even now. And we have studied the young girl, the ovary, which is 2 years, which has so many primordial follicle. And at 7 years, there still are plenty. But when they become big, there is hardly any oocyte. The whole ovary is just removed, the primordial follicle. For what reason, we don't know. But looking at this, the ovarian volume definitely goes down as the age advances. And the ovarian reserve, we all know, also goes down. At puberty, huge number of follicles. And basically at 99% of follicle will go atresia. It's a very pitiable situation where 99% goes away. Something has to be done for that. So by the age of 30 years, only 12% of the pre-birth primordial follicle is actually present. Look at the number, very small number. The female reproduction is an evolutionary aspect, surprisingly poor and inefficient. Oocytes are prone for chromosome error, and women actually utilize only 1% of their ovarian follicle pool. That's a very strange thing to understand physiologically. But look at that. In the mice, the incidence of aneuploidy among fertilized eggs does not exceed 1 to 2%. However, in humans, it is about 10 to 30%. That's the difference. So we all know about anti-Mullerian hormone. I'm not going to talk too much about it. But we should know the normal values are between 1.5 to 3.5 nanogram per ml, and less than 1 itself has to be a little bit kind of alerted. Because it's the only marker of ovarian reserve, independent of the menstrual cycle, unaffected by oral contraceptive pills or GnRH agonists. And the poor AMH, everybody knows, has a poor outcome. And we also know antral follicular count. I always say there are 8 to 10 antral follicular count in each ovary. That's pretty good. And they all have good AMH. Now, look at the aneuploidy rate. 10% of the eggs are aneuploidic in young women, but at 40 years, it is 30%. And at 43 years, it is 50%. And nearly all the eggs are aneuploidic by 45 years. I think age is a very, very important factor. But interestingly, when I was preparing for this talk, I had to go through some literature. There's something called a U-curve. Look, the U-curve sounds very complicated there, but just look at that. You know, look at the age. The U-curve is when it comes down means the best fertility age is around 30 years. Very young women have abnormal oocytes, and the older women also have abnormal oocytes. We never knew that. We always thought the older the women have bad oocytes. But if you don't IVF for a very young girl for some tubal block, sometimes they don't produce eggs at all. That is why, because the U shape is a very important thing to understand. There are high incidence of aneuploidy in a very young woman and obviously at an older woman. So 30 years, it is not 35 years, it is 30 years is the alarming age. So I think the girls, our grandmothers, they get married early and get the first baby soon. And I think I'm being a grandfather now. I know it's very important to say that. Go back to the old system of telling people why, because there is deterioration of the molecular glue. You know, the chromosomes are all kind of, basically the sister chromatids in human oocytes lose the cohesion with age, which may lead to incorrect alignment of the bivalence in meiosis. So when the sister chromatids are loose, they do not perform well. The non-disjunction and significance are also high. In humans, the segregation of the chromosomes is important. If it doesn't happen, there'll be trisomies. Now look at the centromere. We thought genetics is so difficult to understand. I just brought in some few points to understand because we are not so bad to understand actually. So the centromere is the specialized DNA sequence of a chromosome that links a pair of sister chromatids. I said sister chromatids have to be glued together. The central chromosome, centromere also is important there. The difference in the young and the old is the whole chromosome non-disjunction events are preferentially associated with increased aneuploidy in young girls. So young girls also have aneuploidy, whereas centromeric and more extensive cohesion are in the older age group. So ultimately they're all the same kind of problem. They cause aneuploidy, the centromere problem, or the sister chromatid problem. The other cellular activities implicated in declining oocyte quality is the telomere. You know, the telomere is something pink, what's pink there. The ends of the chromosomes are called as telomere. The telomere shortening and eventual exposure of the DNA ends are inevitable consequences of age. The uncapping, look at the bottom slide on the right side, the telomere is very, very small. The older the woman, she loses the telomere. Why should we know about telomere? Because the telomeres are the physical ends of our chromosomes are involved in the control of chromosome stability, genetic integrity, and the cell viability. So the tips of the chromosomes are important, and the telomere goes down and down, down as age advances. Older the women, the less activity. So I always wonder, we should know this point because sometimes nothing really works other than what Sunita was telling a little while ago. I'll be probably have to think about something to inject directly, but I'm not sure about that. Look at the age and inverse. Are we losing the biological clock? If you wait and wait and wait, we are losing the time. So can the ovarian aging be delayed by pharmacological strategies? Actually, not very true. But you should understand certain of these can be manipulated, but it takes some time. The hypoandrogenicity in the poor ovarian reserve, we need to understand the dynamics and the better outcome. We know the androgen goes down and down and down as it advances. And the androgens along with the FSH are very essential for the follicular development. And we know that the androgens and the follicular recruitment goes hand in hand. So all these synergism of FSH and androgen is required. So when a woman has a little bit of a low AMH, probably we need to start androgen, but the literature is not clear about it. But the androgens augment FSH receptor expression in the granulosa cell, amplifying FSH effects on the follicular growth. Now, oocyte response has been beautifully told by Barad et al. I happened to attend the New York conference a couple of times. They're very strong. The group they strongly believe in, the other groups don't believe in. But the DHA seems to be not the answer, at least have some kind of thing. What you should know is it is 25 milligrams 3 times. You must start at least 4 weeks before the cycle. But according to me, it should be 12 weeks. If you give for 1 month, it doesn't really matter. You should give for 12, sometimes 3 months, sometimes 6 months. So more the time you give DHA, then you get some good oocytes. It may be 1, it may be 2. But the number of healthy oocytes becomes better on a prolonged use. So there's no point in starting for 10 days and 5 days, at least 4 weeks, if not for 12 weeks before an IVF cycle. I would like to quote our own friend, Nachandra Chimote. He has done a very beautiful publication in 2015. He studied the clinical pregnancy rate and live birth rate and compared the follicular fluid DHA. Look at the last one. If the follicular fluid DHA is high, more than 1,850 nanograms, they did find a statistically good improvement of pregnancy rate. I told him yesterday I'm going to quote him, and I'm very glad. I hope he listens to me, because one of the very interesting publication I read was Chimote's from Human Reproduction 2015. That means there is some value we cannot discard, because improving follicular recruitment is very, very important for the better results. 17 randomized controlled trial, I've said, 1,400 cases. With DHA, comparison was 26% compared to 15%. But as always in statistics, on removing studies with bias, the increase was not longer seen and there was no insufficient evidence. I think the statistics and all are true, but practically in a selected cases, you give for 3 months and you will get 1 or 2 good oocytes extra than what you don't do. But the testosterone level is important to know. On day 3, testosterone level should be at least 20 nanograms. We fail to do this. I always do this for my patients when I suspect. If the testosterone is low, don't start IVF. Give them this DHA for 3 months. You'll surprisingly find they go 5 times more than pregnancy as you expect. So 20 nanogram is the ideal testosterone. So should androgen supplementation be done before IVF? And we all know Sunkara et al. Has a brilliant way of managing things and publishing. She said the robust data from RCT shows an improvement in live birth rate following DHA in those poor responder. The preference of using DHA as the intervention over other androgen preparation could be justified because DHA results in more physiological level compared to testosterone supplementation. But I think all the all the methods are good, but at least DHA has been proved to be the most initial effective one. In the PLOS study, interestingly, published in 2014, the oxidative stress induces persistent telomeric DNA damage. I mentioned the tips of the chromosome. The telomere kind of gets helped by giving oxidative kind of oxidation. I think the stress inducers may have to be thought about. Oxidative base damage leads to abnormal nuclear morphologies and has been shown to accelerate the shortening of the telomeres. Now, what about immunological aspects for poor reserve? We know that when a woman has all these kinds of problems, Hashimoto's, rheumatoid arthritis, chronic diseases, recurrent implantation failure, Rishma did mention that, but I'm a strong believer of understanding immunological autoimmune diseases must be evaluated in all these failures and these kind of chronically ill patients because they all have anti-nuclear antibodies are positive. The positive ANA, is it connected to pregnancy loss? Simple presence of ANA, however, indicates there is a probability the immune system may be involved. The association is even higher if anti-thyroid antibodies are positive. So when somebody has ANA positive, you do anti-thyroid antibodies. You simply have to give thyroxine in those patients and give probably Viagra, of course, we can modify the immune system by many methods. But however, interestingly, the Chinese always come out with some interesting articles, though we have to probably do a randomized control trial. I just understand we can improve the oxidative stress by anything you want to give. But interestingly, why not improve the food? Nobody has thought of it. Nobody has said eat that and eat this. But I think vitamins, ascorbic acid, vitamin E, N-acetylcysteine, and curcumin. I think everybody talks about this, haldi. And you find all these are not literature proved, but I think we can get a dietitian to do some PhD studies on this in this country. And I think Sanjeev Reddy would probably take it up very seriously, which I would do it also in my level, because the grape seeds and so many things. But look at that mTOR. The mTOR signaling has been kind of forgotten. The mTOR is very, very important in the aging. Because the time factor, I will probably end by saying that epigenetic regulators are also important. Now, what is this resveratrol and melatonin? The potential autophagy inducers. Melatonin is of quite capable of delaying ovarian aging. And I've written that telomerase length. Everything is connected to the telomerase length. If it can be increased by these kind of manipulation, I think we'll get some kind of answer. However, resveratrol, an important phytoantioxidant, commonly found in grapes, mulberry, and plants. So I was very fascinated by this. I think we can at least advise something in the diet itself, but they're all anti-inflammatory activity. I would like to conclude by saying, look at this. It's a confusion of balloons going up. All these matters in some way. However, please understand, ovarian aging cannot be manipulated thoroughly, but I think the stem cell may be the answer, but not yet proved. There are no randomized control trials regarding that. And the take-home message would be reductions in oocyte quantity and the quality inherent to the age results in clinical subfertility, increases miscarriage in very young and older people. The very young, nobody spoke about. Inverse U, the curve of natural fertility for the very young and the very old is distinctly different, but acts similarly. An improved understanding of the mechanisms involved with all these things can be developed subsequently with biomarkers and the prediction of a very good methodology subsequently. Thank you very much. This is Manipal by my university, just for you to see that. And I come from Karnataka state. We are still in darkness there. Our COVID rates is going up. So thank you once again for your patient listening and inviting me.
Thank you, Pradhan, for lovely presentation.
Thank you, Kamala.
Moderators.
Hi. Greetings from Tirunelveli. It's a great pleasure to introduce Dr. Sonal Panchal, who is the consultant of Dr. Nagory's Institute of Infertility and IVF. She's also a professor of Dubrovnik International University and academic director of the Indonol School of Ultrasound in India, which is quite popular in Tirunelveli too. The pinnacle of success for any academician is either to teach or to do original work, and Dr. Sonal Panchal has managed to do both. She has presented published papers in national and international conferences and is a voracious writer, having published several books, two of which I have read. So over to you, Dr. Sonal Panchal, who's here to talk about how the endometrium mirrors follicular development on ultrasound.
Thank you very much for those very kind words. Can you please, yeah, thank you. So at the outset, I would sincerely thank Kamala ma'am and Sanjeev sir for giving me this opportunity and allowing me to talk on something which is very close to my heart. Endometrium, we all know, is a receptor organ for the ovarian hormones, and morphological and vascular changes of the endometrium are reflections of hormonal changes which are occurring during the menstrual cycle. We all know that it is estrogen which is responsible for the proliferation of the endometrial layers and the cell layers and the glands, and it regularizes the peristalsis also. Whereas progesterone, we all know, it compacts the endometrium and it converts, it makes up necessary changes to make it capable of implantation. It pacifies the endometrium too. But that is too much of an just a true bird's eye view. If we go a little more into detail, we know that the shedding of the endometrium occurs at the menstruation because of deprivation of estrogen and progesterone both, and the endometrium becomes almost a single line. But sometimes you may also find some fluid inside, which is blood, and you may also find clots and fresh blood, which give us a heterogeneous appearance. It is very important to remember that a hyperechoic looking or a heterogeneous endometrium during the menstruation is not always a thick endometrium. Put on the Dopplers and confirm it's blood or no blood. Or it's blood or it is an active endometrium. Normally, the endometrium in the during the menstruation will not show any blood flows, not only in the endometrium but also in the subendometrium. As the estrogen starts rising with the recruitment of the follicles, the endometrium starts growing and it becomes multilayered as early as about day 6 or 7 of the normal length cycle. And it appears really, really thin then though, and then gradually keeps on growing at a rate of about 0.3 to 0.5, and in some patients up to 1 millimeter a day, to reach to about 7 to 12 millimeters just before the ovulation. Depending on the development of the vascularity in the endometrium, stromal edema and amount of glycogen storage in its columnar epithelium, which are all the effect of rising estrogen, we may find various morphologies of the endometrium, where the endometrium may be multilayered with hypoechoic areas in between the lines, which is called a grade B endometrium, or a multi-layered endometrium with ecogenic, small ecogenicities in between the lines, which is not more than that of the normal anterior myometrium, which is called a grade A endometrium, or it may lose the triple layer pattern, but still become just homogeneous isoechoic to the myometrium, not hyperechoic. And these are all different kinds of estrogenized endometrium. These are not the effect of progesterone at all. With the follicular development, there's also rise in the endometrial vascularity. The branches of the spiral vessels, they start developing towards the endometrium and they reach maximum about 3 days before the ovulation. Just before the surge, just after the surge starts, just before the ovulation, we know that the progesterone level actually rises, and this is shown as mild fluffiness of the outer margin of the endometrium. And this first it becomes fluffy, then it becomes hyperechoic, and then this hyperechogenicity gradually progresses towards the center to make the entire endometrium hyperechoic in the mid-luteal phase. That means the endometrium still remains multi-layered till about 6 or 7 days post-ovulation, and this is very important to understand. Not immediately after the ovulation, the endometrium becomes hyperechoic. If it does happen, it is an advanced luteal phase. It is the progesterone which leads to compacting of the endometrium. So the endometrial thickness also decreases by about 0.5 millimeters in the early luteal phase, and then it gradually increases to reach 2 millimeters beyond the maximum proliferative thickness, and this is called a normal secretory change. apart from the hyperechogenicity that we observe. Not only that, even the vascularity increases. I mean, the vascularity is maximum pre-ovulatory. It decreases immediately after the ovulation and then again increases. The resistance decreases in the mid-luteal phase to reach about RI of 0.5. Along with that, to supply the implanting embryo, the uterine artery PI also decreases and it reaches 2.5, which was as high as about 3.2 pre-ovulatory. Beyond the conception, beyond the mid-luteal phase, if it is a non-conception cycle, the thickness of the endometrium decreases, the vascularity decreases in abundance, and the resistance also increases. Whereas if it was a conception cycle, the vascularity persists, the endometrium may grow in thickness or remain constant. The PSV may reach as high as 5 centimeters per second for the spiral vessels. Not only that, in the late uterine phase, if it is a conception cycle, you can typically see asymmetrical thickening of the endometrial leaps. You can see here the posterior lip is more thickened than the anterior, and moreover, you may also see, which is typically described as a color comet sign, where you see multiple vessels heading towards one particular hyperechoic spots, and this is a sign of an early pregnancy. Mind you, it may be seen as early as in the late luteal phase. But this is what happens in a natural cycle. In the stimulated cycle, the endometrium behaves a little different because we are giving a lot of exogenous hormones and they may be beyond the physiological levels. If you're talking about the CC cycle, which is not, CC is not very commonly used now, but CC has been always blamed for a bad endometrium. But it's very important to remember here that in the CC cycle, though when the follicle reaches about 17-18 millimeters, the endometrium is going to be thin because this happens a little early or a little before the follicle really becomes mature. In CC cycles, the follicle becomes mature about 22, 23 millimeter in diameter. Beyond 18 millimeters of follicular size, from 18 millimeters to 22 millimeters, which occurs a little late in the follicular phase. It is this time when the CC effect is weaning off, the anti-estrogenic effect is decreasing, and moreover, the follicle is actually getting functionally mature. It will increase the estrogen secretion, and therefore late in the proliferative phase, there's a sudden increase in the endometrial thickness. So all the patients, you do not have a bad endometrium, it's only coming late because the follicular maturity is late. In gonadotrophin cycles, though, the endometrial thickness usually reaches a little more than what it is in the natural cycles. Here also the endometrium changes its morphology from what we say grade B to grade A and from grade A to grade C, and it is very important to remember that whatever the morphology, the implantation rates may be good. If that is the cause, if that is the effect, then why should we check the morphology? We have to check the morphology because the morphology correlates with the estrogen levels. If you just have one follicle, one mature follicle, you usually expect a grade B endometrium. But if you have a grade A endometrium, that means the estrogen levels are truly great, the follicle quality is great, and you are likely to get very good results with that. But if you have multiple follicles and you still have a grade B endometrium, it's truly not a good sign because these follicles will not give you very good ova and the chances of conception would be less in spite of getting more follicles. But if you get a nice grade C endometrium with those multiple follicles, that's what you expect because grade C indicates higher estrogen levels. Usually when there are 1 or 2 follicles, you get grade B endometrium. When there are 3, 4, 5, 6, you would usually get grade A endometrium. And when there are truly multiple follicles, you'll get grade C endometrium. In PCO patients, even when you have a unifollicular, monofollicular development, even then you may have still a grade C endometrium, and this is normal and natural because the other small follicles are still going to produce some estrogen and therefore the total estrogen level is high. Apart from this, you may also see cervical mucus, which is also a representative of presence of estrogen. There may be also some fluid seen in the endometrial cavity. If it is just a slight slit of fluid, as you're seeing there, which does not persist for more than about 24 hours, this may be considered a good sign, a sign of a good estrogen. But if it is persistent and it shows hyperechoic inner walls, this is not a good sign, and it may affect implantation. Nearly the same time, when the follicular vascularity develops, the endometrial vascularity also starts growing, and this is also the effect of estrogen, apart from the endometrial thickness, morphology, and the cervical mucus. And we have already known that it reaches maximum about 3 days before the ovulation. This vascularity must reach the inner layers of the endometrium. It is these two types of vascularity which is considered good for implantation, where the vascularity is, the blood vessels are reaching the inner layers of the endometrium, the intervening area, as well as the central line. And these are called zone 3 and zone 4 vascularity. And these blood vessels must have a low RI, and they also should have cover 5 millimeter square area. When you get this, that means the estrogen that is being secreted by the follicle is well perceived by the endometrium. That means that the estrogen receptor development is also good. When this is achieved, it therefore indicates not only a good estrogen level, it also indicates a good quality endometrium which has sufficient estrogen receptors developed. And if there is sufficient estrogen receptor, then sufficient estrogen priming, and therefore a good chance for the progesterone receptors to develop. This vascularity is a prognostic marker better than any other markers to tell you that the pregnancy is likely to grow. So it's a good sign of an ongoing pregnancy. If it's not present, it is a strong sign of failure of implantation. Not only that, even if the implantation occurs, there's a high chance that it may result into a spontaneous miscarriage. And this has been proved in one of our studies also. There were several other studies on that too. It is also important that you check that the uterine artery PI at this stage is less than 3.2. And when you get these parameters, again, I repeat, you know that the estrogen level is sufficient. You also know that the estrogen is sufficiently perceived by the endometrium. So both are correlating, the maturity of the follicle and the receptivity of the endometrium. And therefore, in IUI cycles and in fresh transfer IVF cycles, you must wait for these parameters of the endometrium to be achieved before you give a trigger, and the same parameters before you start progesterone for your frozen cycles. Now, as we know, at the start of, the progesterone level actually starts rising before the ovulation occurs, after the surge starts, and that results into fluffiness of the outer margin of the endometrium, as has been described. And if you get this fluffiness, along with more than one follicles, which has nice cumulus, which has nice blood flow, low resistance blood flow, it indicates that the surge is about to start, or it is an impending rupture, and it also indicates good quality follicles. But it is about 24 hours after the progesterone exposure, the outer margin of the endometrium starts becoming hyperechoic. And if you see this hyperechoic margins on the day of ovulation, on the day of trigger, it is not a good sign, because that indicates the pathological levels of progesterone, which is said as 1.5 nanograms, more than 1.5 nanograms, up to the fluffy appearance. It is a physiological level, and that is preferred. You may, later on, this hyperechogenicity starts progressing towards the center, and you usually see this type of a picture day 4 or 5 of the luteal phase, which is the time when you're going to do your blastocyst transfers. The trigger induces significant increase in the resistance of the uterine artery and also decrease in the endometrial flow. And this is because with the start of the surge, there is a fall in the estrogen level. The progesterone levels are still low. In absence of estrogen and progesterone, both the uterine flow is going to decrease. And this is a healthy sign. That means if you have a high uterine artery PI with a follicular PSV which is low, because the follicular PSV needs to be 10 centimeters per second for a mature follicle. If it's low, that means the follicle is still not mature and you need to continue stimulation. But if the follicular PSV is high, which happens when the LH surge starts, in that case, it is an impending rupture and you might have to do an earlier IUI or a double IUI. The endometrial vascularity, which is decreased immediately after the surge, again starts increasing towards the mid-luteal phase. That means it is very important to remember that when you do the transfer, whether it's a day 3 transfer or day 5 transfer, the endometrial morphology and the vascularity are different. That is pre-ovulatory, that is about day 3 transfer, and that is day 5 transfer. Similarly, the vascularity is less when it is a day 3 transfer. So don't check the vascularity on the day of the transfer, check it on the day of starting progesterone. A quick look into the luteal phase or the effect of progesterone on the endometrium. We all know the endometrium becomes hyperechoic, but checking the vascularity will tell us about the progesterone level, tell us that the progesterone levels are normal or not. And if the RI is less than 0.5, it is a clear representative of the progesterone secretion and by the corpus luteum. And if the spiral artery blood vessels also show an RI of less than 0.5 and sufficient vascularity in the entire endometrium, it tells us that the progesterone receptors are well developed, along with the uterine artery PI also less than 2.5. That means if there is a luteal, if these are not the parameters, that means there's a luteal phase problem. If there's a luteal phase problem, it may be low progesterone or the progesterone is not perceived by the endometrium. If it's a low progesterone, it may be LUF or it may be an LPD with a corpus luteal failure. Corpus luteal failure will show as a low flow in the corpus luteum and a thin hypovascular endometrium. Whereas LUF will show no corpus luteum, persistent follicle, hyperechoic wall, low level into echogenicity inside, and a high RI there. Whereas if it is just a receptor defect, the corpus luteum will be normal and still the endometrium will be thin and hypovascular. So coming to the message to store in your memory.
2 more minutes.
Just 3 summary slides. During the menstruation, the endometrium breaks through to very low estrogen and progesterone, and single line endometrium or blood in the endometrial cavity, recruitment of the follicles, which leads to rise in estrogen, leads to multi-layer thickening of the endometrium and making it multi-layer. With the dominance of the follicle, the endometrium starts growing 1 to 2 millimeter a day, and the vascularity also starts increasing. At the maturity, you would expect the endometrium to be 8 to 10 millimeters, with an vascularity reaching zone 3-4, with RI of less than 0.5, with PI of the uterine artery less than 3.2. These all tell us the proliferative phase is superb and you can go ahead with the trigger. Impending rupture, outer margin becomes fluffy few hours before the ovulation, endometrial vascularity decreases, the uterine artery resistance increases, and as the corpus luteum starts working, the progesterone is produced, again the vascularity comes up, again the resistance in the uterine artery decreases, the endometrium starts becoming hyperechoic from outside, and beyond this phase, the changes depend on the presence or absence of the conception. Thank you very much.
Thank you, ma'am. Illustrative slides, brilliant explanations. Thank you. Over to the next moderator, Aarti.
Thank you so much for the wonderful speech and also keeping up to time. Thank you so much. Thanks a lot.
Good afternoon, everyone. Now let's move to the most awaited talk of the day, the future of assisted reproduction. To talk about this, I would like to welcome the much sought after speaker, Dr. Durusha ma'am. She is the Scientific Director of Gynec World, Mumbai, founder and managing trustee, Women's Empowerment Foundation, founder president, the PCOS Society of India, and trustee, Mumbai Obs and Gynec Society. She has held various positions in major organizations of Obs and Gynae and assisted reproduction. And she has got a lot of awards nationally and internationally. And I should tell that she's the first Indian to have ever received the prestigious Distinguished Merit Award from FIGO at World Congress, Italy in 2012. She has been conferred an honorary fellowship for her work by OCOG in 2008, and she is one of the top 20 women achievers of Indian healthcare. Her passion has always been to focus on preventive health in young girls, and she's engaged with several social activities like Growing Up Kishori, Save the Mothers for Maternal Health Care, and currently she is focusing on breaking the silence on violence, combating sexual abuse, especially in young girls. And she's a prolific writer who has edited and authored more than 200 journals and topics in textbooks of OBS and Gynae. And like everyone, I'm eager to hear what she's going to tell about the future of ART. Dr. Durusha, please.
Welcome, Dr. Durusha. Nice meeting you.
Seeing your program. Are you seeing my presentation?
No.
No?
Oh. To get into the Zoom. Are you seeing it now?
Yes.
Yes. Yes.
Good. I'll first of all thank the organizers for having invited me to this wonderful meeting. And I will go ahead straight to the topic of assisted reproduction. If you talk about Steptoe and Edwards way back between 1968 and 78, they did some real pioneering work in human IVF. And they put in a lot of effort and brought to us the utilization of this wonderful technology called in vitro fertilization. Initially, there was a lot of criticism on their work, and this was mainly creating a lot of issues for them. In their first 40 patients, there was no pregnancy. In 1976, Mrs. Leslie Brown saw Steptoe, and she had the first IVF pregnancy. Unfortunately, it was an ectopic through a single blastocyst transfer after a total of 102 attempts at pregnancy. Finally, she was pregnant, and that was the baby of the century born, who was Louis Brown, way back in 25th of July, 1978, exactly 42 years ago. Now, both of them, Patrick Steptoe, the clinician, and Robert Edwards, the embryologist, both have received the Nobel Prize for this technology. And this is something which over the last 42 years, millions of babies have been born worldwide, and so many infertile couples have been benefited. There have been extreme amount of advances and improvements in laboratory and clinical procedures with the use of ultrasound, hormone assays, ovulation induction, gonadotrophins, agonist, antagonist, ovum pickup through ultrasound, embryo transfer under ultrasound, and this treatment has been made available all worldwide. Following which came the newer technologies of vitrification, pre-implantation, screening and diagnosis. Animal cloning has become possible, but human cloning is still restricted. There was reproductive tourism, so there is surrogacy, a lot of international surrogacy we had, designer babies, ovarian and uterine transplants, mitochondrial donation, stem cells. All this has been made possible for us to use. But there have been a lot of ethical concerns with social implications. And the complaints, the implications were that when we put in a lot of embryos to get better pregnancy rates, we are creating multiple pregnancies, which increases the risk of prematurity, and therefore there have been a lot of regulations which have come into play, with UK being the first country to impose it, and they have campaigned for a single embryo transfer so that they can target less than 10% of multiple pregnancies, though the pregnancy rates get lowered by putting in only one embryo. So why is it that today, that though 50% or 50 to 70% of couples who undergo therapy, they fail at each attempt? Why are we as ART practitioners not better at what we do? Why have we got paused at the implantation phase for the last 10 years? Is it the embryo or is it the endometrium? That's the constant question being asked. What causes this failure, and how much do we know today? can technology one day, in a patient, in a couple who's undergoing IVF, we empathize with them? We need to make sure that they do not have too much of emotional and financial strain on them. And even after spending so much for an IVF cycle, waiting for hours in IVF center lounges, and then having only 30 to 40% success rate, this is something we as clinicians, we need to devise better protocols of achieving success. We need better embryology labs to put in so that we can put in only one embryo and have 100% guarantee of success. So what can we do to achieve a pregnancy with just one attempt at IVF and get rid of all the chances of multiple pregnancies simultaneously? And today I'm going to focus on the use of artificial intelligence in assisted reproduction. There have been many other developments in the field of ART, and one of them is in the field of genetics. But since we have limited time, I'm going to restrict myself to artificial intelligence. Now, what really is artificial intelligence? Artificial intelligence is the duplication of human intelligence processes by machines, especially by computer systems. These processes include learning. By learning, we mean the computer acquires information, it collects information, it reasons, it uses the rules which are put into it to reach conclusions, and it helps to self-correct itself using the rules to recorrect itself. So these rules are put in as a software information into the computers, and this is what the computer does, and this is called artificial intelligence. It's a learning by the computer-based algorithms that involve a computing strategy or neural network. This is called deep learning, and this is where there is almost a three-dimensional issue going on inside the computer, which is called the neural network. And it helps to it makes the machine tell us more about knowing that. Knowing means, like say for a child who is cycling, learning to cycle, he knows he could fall. And he can avoid falling by knowing how to avoid it through learning. Similarly, a computer is taught what is knowing that and what is knowing how. And when we touch, it's something like this, that when we touch something hot, we get a blister. The human brain tries to determine why did the blister occur, but the machine will not be able to determine why a certain action took place. So in short, that learning is something what we as human beings can learn as to why things happen. The brain understands a blister and why it occurs. The brain can investigate whilst the machine cannot. We know that the blister occurs due to an inflammatory cascade of prostaglandins due to the burn and cytokines in a regulated process, which we still don't understand perfectly, but we will keep asking the question why till we know the answer, which a computer will do the rest of the stuff, but it cannot investigate as of now. This artificial intelligence, the word has been first coined by a group of researchers in 1995. And since then, applications have been used in daily lives. Like we have automated vehicles on the road. We have facial recognition on our face. So when you open the phone, if you've got the latest model, the phone sees your face, recognizes it, and knows it is you and opens up. But unfortunately, if a woman who's using makeup in the day and has her face on with the makeup, early morning, the face may not recognize her. So the phone may not recognize her. And there is intelligent voice assistance where we say something, and like Siri, when we talk on an iPad, we use Siri to auto type our speech. And also in smartphones, you can auto type when you speak. The phone recognizes your voice and it recognizes the way you speak. Similarly, there are other things which go on, like the Blue Dart service. You can track your parcel, where it has reached. You call for an Uber taxi and you know where the taxi has reached. You wear a 24, it came into medicine, artificial intelligence came into medicine by the 24-hour Holter test, which was a nuisance value because the patient had to be admitted in the hospital for 24 hours to determine a Holter test. But now when he wears this Apple Watch, wherein he drives to the hospital, gets the gadget fitted, wears it for 24 hours at home, goes back to the hospital for the doctor to see and interpret it. But now with the Apple Watch, the tracing is sent to the doctor for interpretation on the computer, and it's sent to the patient. The doctor interprets it, sends it back to the patient with the diagnosis, and the patient then decides whether to go to the hospital or not. It's making life so much easier when we use artificial intelligence in day-to-day practice. In healthcare, it's already being used in oncology, radiology, cardiology. But in late 1990s, the application of artificial intelligence came into assisted reproduction, and it also came into oocyte and embryo selection. There's a lot of immense ongoing research on the embryo and endometrium. But today we know that artificial intelligence will assist in selecting the best embryo to implant and the best time to transfer. And then we may be able to offer a better pregnancy rate to our patients. Currently, the pregnancy rate is about 4.5% per oocyte, which we retrieve. And the assessment today is based on morphology and developmental competence. And we grade our embryos. And we need new non-invasive biomarkers instead of doing a biopsy, which is invasive, a pre-implantation biopsy to know its capability. We do want new non-invasive biomarkers, and therefore AI algorithms have been developed and have been used, and a lot of studies have been carried out with them. What they assess is they look at the cytoplasmic movement velocity, which is accurate in 91.03% of patients assessed by, embryos assessed by artificial neural networks. They also measure the viscoelastic properties of human zygotes hours after fertilization with 90% precision. We know that PGS is invasive, and these embryos today have been photographed, which recognize subtle textures which are not visible to the human eye, and they are linked through statistical models to metabolism and DNA damage in that particular embryo. So currently all this is helped with artificial intelligence, and a lot of automated digital images are fed into the computer to analyze the embryos and grade them. And these are done by naked eye assessment through by the embryologist with a microscope, and all this data is fed into the computer, and a lot of images are fed in to get the information you require for the computer to learn. Now, this study, which is done to develop and validate an AI system, predicts the probability of clinical pregnancy through time-lapse videos. So in this, the design was that all the embryos were included regardless of their development, and data from 8 laboratories in 4 countries from 2014 to 2018 were included, with the mean age of patients being 35.6 years. The primary outcome was to detect a fetal heart at 6 to 8 weeks of gestation. A total of 2,000 embryos were transferred, and 73% of them were single embryo transfer, and 670 embryos resulted in a clinical pregnancy, with 8,389 embryos had known fetal heart outcome data. On that, the results showed that there was an accuracy of 93%, wherein the machine could tell that this particular embryo will progress to a fetal heartbeat. And therefore, AI is an automated, non-invasive and highly discriminative embryo ranking tool for time-lapse generated embryos to predict its progress to a fetal heart. Where it comes to sperms, AI also helps to select sperms by morphology and kinetics. It helps to predict and diagnose abnormal sperms using testicular volume, FSH, LH, and also total testosterone and ejaculate volume with 95% accuracy. So in short, even with sperms, it's able to help. There's a lot of research, there are a lot of strategies today available. And this team, Freguli and team, have been working on the mitochondrial DNA levels in the blastocyst to be implanted. And surprisingly, when we talk about eggs, we say the higher the amount of mitochondrial DNA, better is the quality of the egg. But when it comes to a blastocyst, they find that the higher the mitochondrial DNA in a blastocyst, lower is the chance of it implanting. So there seems to be quite a bit of controversy on mitochondrial DNA in an egg versus a blastocyst. While Stanford's researchers are focusing on the squishiness of an embryo, the amount of resistance to a slight squeeze from a pipette predicts whether the embryo has a higher chance of implantation. It helps to predict 90% of the times as to which embryo will reach the blastocyst stage. The other experiment being followed up is where they find that human eggs radiate zinc when they are injected with sperm enzyme. And researchers from Northwestern University are studying the sparks of zinc which an egg releases when it is fertilized. And the idea is to develop a device which can detect these zinc sparks as fluorescent sparks in a way that embryologists can detect the most promising fertilized eggs which should be used for transfer. So unfortunately, we have a lot of unreliable prediction of results of embryo quality when different embryologists look at the same embryos. And therefore, this leads to transfer of multiple embryos to improve success rates. And therefore, this AI approach was based on deep neural networks, was carried out using about 50,000 images of various embryos. Now they use the framework called STORC. This is a framework of artificial intelligence which has been developed and predicts the blastocyst quality with an area under the curve of more than 0.98, and it outperforms individual embryologists. So using time-lapse images data from 2,182 embryos, a decision tree was created to integrate patient age, because two important factors which we require for implantation is patient's age and embryo quality in order to predict IVF income. Now, the STORC analysis showed that the chance of pregnancy based on individual embryos varied from 13.8% in women above more than 41 years, and it went up to 66.3% in women who were less than 37 years with good quality embryos. So this AI-driven approach helped a lot. And if you look at when they compared it to the embryologist looking at it by themselves, if you look at embryo A, the embryologist had mentioned that it is a poor embryo, and the STORC AI had mentioned it's a good embryo. But when they did when they looked at the results, the results showed that pregnancy was positive in such patients, and therefore the good embryo which was detected by STORC gave a better answer. So similarly, if you see in the C and D, it's a similar story. Now here there are 5 embryologists who were working on this project, and each one of them gave different grading to those embryos. The yellow is the good, navy blue is poor, fair is the grayish, and uncertain is red. So you'll see all these different grades, and the outermost circle is the one which is by STORC, and it had shown so many embryos which were not good, and only the right upper hand you'll see in the upper quadrant right side, all yellow, which were the good embryos. So in short, when they compared it from embryologist to embryologist, there was a difference, while STORC gave better results compared to the embryologist. Then this decision tree was made by adding another computer-aided program into this called CHADE. And they added age and quality to it. And based on that, they could decide which were the best embryos to transfer. So the benefits of AI is that it has the ability to identify high quality normal embryos from the cohort. It helps to assist IVF experts in selecting the best embryos for implantation. This will improve the efficiency of assisted reproduction. It will improve subsequent pregnancy outcomes. It will help us to know which are the best treatment options, best patient care we will be able to deliver, and it will minimize the healthcare cost of unnecessary testing and failures. But the concern always is that, is it going to replace embryologists? But no, it will not. It will only give an auxiliary tool to them to help them in order to select the best embryos. The second issue is about legal issues. If an AI identifies an abnormal embryo as a normal embryo, Who will be blamed? Will it be the computer or will it be the embryologist? And third is, could the technology be misused for designing embryos with the best genes? Now, with use of pre-implantation genetic diagnosis, we are able to identify the best embryos. And therefore, when this technology is used, we could use it for designing embryos. There has been a Montreal Declaration, which is in 2018, brought in by, which is an initiative of the University of Montreal, which is born from an inclusive deliberative process. And this is based on various principles which exist, that is the well-being. It also depends on respect for autonomy, solidarity, equity, etc., etc. But this has been created, and at the moment, the Canadian Association of Radiologists has created recommendations based on these principles, but still there are many more recommendations need to come, because these recommendations inform the association, the ministers, the policymakers on what should be done, what should not be done. It should help partnerships with researchers, with implementation, with clinical application, and also governances. So all this is very, very necessary. And the fear is that it's our perennial anxiety. Since we have had the phone, we can't remember anybody's numbers. And we don't even make an effort to memorize them because it's there. So will the same thing happen to us in medicine? Because we are becoming less and less trying to use less and less of our own brain because we're depending too much on technology. But we must remember that these technologies are meant to assist the embryology, and the use of artificial intelligence will help in making them more accurate with a quicker diagnosis. Today, we are actually dealing with robots which already exist, Sophie and Pepper. Today, they have no emotions like us. They just do their jobs very, very silently. But 30 years later, they will learn by themselves and laugh at us because they will be cute and super smart, 1,000,000 times smarter than us. The power of the brain has no limit. But 30 years later, we will be better at our imagination and our feelings, the gut feeling, because the routine jobs will be done by robots, and we will work with our imagination to do much better for our patients. As Japanese billionaire SoftBank CEO Masayoshi Son has said, in about 30 years, AI will have an IQ of 10,000, when the average IQ of a human is 100 and that of a genius is 200. It's possible that the machine learning will become smarter than the human brain, and it will happen in this century. So we all need to shape a world where instead of just banning research and new technologies, we should embrace them for maximum benefit with as little harm as humanly possible. I thank you all for your kind attention, and I invite you all to participate in our PCOS quizzes, a planned program of the PCOS Society starting 15th of August with huge prizes to be won. Get all details onto our website, and we'll happy to have you with us. So again, thank you very much for all that we have, for inviting us and for participating in this lecture. Thank you very much.
Thank you very much, ma'am, for the lucid presentation. We know that the future holds many promising advanced technologies. We are happy that we can give a good success rate to our patients, but at the time we feel a little bit scary to follow all this. I now hand over the session to the second session moderators for the interactive session with their respective speakers. Dr. Ashok.
Go for the question.
Yeah.
There's actually one question for Dr. Pratap sir in the chat
Thank
section.
you, Dr. Guru. It was short. It was wonderful.
Thank you so much.
Wonderful.
The question to Dr. Pratap sir was, metformin and growth hormone in ovarian aging, is there a role?
The metformin is basically for polycystic ovarian problem, and the growth hormone is also for the stimulation of the oocytes in certain of these difficult situations. But they have not actually really done for an ovarian aging. It has not been studied saying that is beneficial. So by starting metformin, you're wasting time. And the growth hormone also is a plus or minus kind of studies have come up. So at the moment, the studies are not clear about it.
You said that DHA is quite useful for ovarian aging patients, but how many months can you give it before you can drop it?
I did mention that in my talk. I'm not saying it is very useful because there are controversial literature, but the articles which I have gone through and have studied that is you should give at least for 3 to 6 months. Minimum is 4 weeks before IVF, but it doesn't work. My experiences I've given for 3 months and then the AMH doesn't increase, but at least I may get one extra oocyte and one good embryo. So I think the minimum time should be minimum 3 months, if not 6 months.
Can you allow her to go for a natural conception, or you should have go ahead with IVF once you've given your DHAs?
No, I think all these patients, natural conception is extremely low, but there are sporadic events anyway. So I think they're all meant for IVF as such. Once you improve the androgenicity, you have to do IVF. There's no doubt about it.
Thank you, sir. Thank you.
I have a question for Dr. Sonal Panchal. The question comes from Dr. Kanchana Devi, and her question is how to tackle thick endometrium when you're planning an FET cycle. Ma'am, you're on mute.
The question is, how thick is thick? Up to about, say, if you go in terms of volumes, up to about 7 ml, which reaches about 15, 16 millimeters. Usually it's not a problem. We also believe that if the endometrium is thick, but the morphology is normal and the vascularity is good, you can still go ahead with the transfers. If you're really talking about a hypertrophic endometrium, we all know with hypertrophic endometria, the vascularity is also less, and in these cases, we have to give a withdrawal and regrow the endometrium.
Thank you, ma'am. I have a question for Dr. Pratap. Sir, do you think it would be possible to postpone menopause in the near future?
I think it's a difficult question to answer. I don't think we can postpone. Maybe we can just generate few extra eggs in these kind of women. And the nature has already decided when menopause has to occur for that particular individual. That is why we are finding a lot of young girls also getting into menopause called premature and failure. They're all, of course, if there's autoimmunity in those kind of patients, I am a strong believer of autoimmunity. In the young girls, if there are low AMH and low eggs, you should do autoimmune testing and manipulate the immunity in them. I think the natural menopause, I don't think can be postponed.
Ma'am, there is a question for Dr. Rishma. Ma'am, are you there?
Yes.
Yeah.
Okay. Role of low-dose HCG in thin endometrium. What is the role of low-dose HCG?
So there are many ways in which HCG works. Most of us use it as a trigger, and we know that it continues because of its long half-life to work for a long time. And it also seems to have a fair amount of immunological benefits. So people have been using, and I've shown some studies with intrauterine infusion of HCG. That's one way of using it. Stem cells activated with HCG are being used, and very small doses of HCG, like 500 units, have been subcutaneously injected and also seem to have some benefit. Problem happens right now in India, we don't have very, very small doses available. The minimum, I think, is about 2,000 units. So to be able to make a small 500 units calculation is difficult. But in most of these methods, it seems to help, maybe not increase so much the endometrial thickness, but helps improve implantation, possibly by some immunogenic mechanisms.
Okay. There's one more question on intrauterine probiotics for RIF. Any experience on intrauterine probiotics?
No, nothing right now. All I can say really is there's a huge focus on probiotics and on basically the microbiome, not only of the uterus and the endometrium, but also the vaginal. So when the embryo transfer catheter is going in, they've actually analyzed the catheter tip for the microbes. And, so huge amount of focus on that, because these millions of bacteria which live in the endometrium, which live in the vagina, produce the products which are then analyzed, and they hugely influence. So I think the future is going to be a lot of focus on the microbiome of the vagina, of the uterus, and its influence on implantation and pregnancy, and the use of probiotics to influence them. We've been using oral for a very long time, oral probiotics. Now we have vaginal probiotics, and at least I'm not aware of intrauterine probiotics, but definitely checking for endometritis, tests to prove that endometritis is there, and specifically treating with even intrauterine infusion of antibiotics. So there's a big change happening from what we had just a few years earlier.
Thank you, ma'am.
Long time back when we were postgraduates, they used to put intrauterine gentamicin and even ciprofloxacin. That's coming back.
Coming back.
We have a lot of appreciations for Dr. Dursha ma'am's talk, and I have one question relating to artificial intelligence. I don't know whether it's to Dr. Pratap Kumar sir or to Dr. Dursha ma'am. They're asking whether we can postpone menopause with artificial intelligence or stem cell therapy.
If you want me to answer, then artificial intelligence is not going to help with postponing menopause. It's only a tool to be used for doing whatever you wish to do, to identify. Maybe you'll be able to identify patients who are likely to go into premature menopause. And maybe those are the women, if we are talking fertility point of view, we can freeze their eggs and keep them, because we do a lot of social freezing today for women who are into careers and who are getting remarried at an older age. So, or going through divorces and then getting married again after a few years. So that kind of thing, probably artificial intelligence will be able to help us identify those women who are likely to reach premature menopause. So probably that's what it's going to do.
Yeah, Dursha, I agree with you, because no amount of intelligence and whatever kind of intelligence will prevent menopause. It can only identify these kind of people who are getting into earlier menopause. I think that's a good statement. Correct.
Thank you, sir. Thank you, ma'am.
I think somebody has asked about split ejaculate, which cases you can help in split ejaculate. I think Dr. Pratap.
No,
somebody has asked.
Kedar will answer that, because he spoke about IUI. No?
For which cases you can?
You have to unmute, Kedar. Unmute yourself. Kedar, you have to unmute.
I see. Okay.
Yes, yeah, I got it. Yeah. Okay. Okay. Yeah. Yeah. So actually, a split ejaculate is supposed to give you an ejaculate in which the first ejaculate part gives you a higher concentration of sperms, followed by the rest of the ejaculated, which is supposed to contain more of the fluid coming from the seminal vesicles. However, it is not always true, and we find that there is very often a uniform presence of sperms in the ejaculate.
Thank you. Somebody had asked.
There was one question to Reshma, madam. Patient with a poor endometrium does not improve with any drug. Any other modality do I have to manage this patient? That's from Dr. Suma from Coimbatore.
Essentially, resistant endometrium, which is not working at all, right? Yeah. I think it's really about being not having enough systems to evaluate. Now you saw in my talk today, we talked about so many different methods to analyze the endometrium, starting from hysteroscopy for any adhesions. Tuberculosis in our country, I think, is huge, and it's a possibility of missing that diagnosis, and which is why, that endometrium is just not responsive. And it could, of course, be, like I said, endometrial biopsies today to evaluate, or even endometriosis outside with the Receptiva test, you'll be able to pick up its negative impact on the endometrium. Adenomyosis. So there's so many different things, the microbiome, the probiotic influence, of the microbiomes. So there are so many different things which affect the endometrium, the receptors. So there is literally a massive test range which we have, which we probably are not able to conduct all, and that's why we are not evaluating. And also then we went on to treatments, and like I said, everything from aspirin to estrogen to arginine to GCSF to HCG to stem cells, everything is being tried. So I think it's probably lacking somewhere in investigation and in treatment. Not that you are lacking, probably knowledge is lacking. And one day we'll be able to overcome that. But at the present moment, once you've tried everything, you have to move on either to surrogacy or something similar.
And how long will you use probiotics before an IVF procedure?
It does take, I don't think there's an exact timing as to how much time it takes for a probiotic to alter the milieu, but it has been found that if there is almost completely lactobacilli in the environment, it's very, very beneficial. So I would recommend that you give a nice course of probiotics, and with the simple methods that we have today, you can actually evaluate the, you have the Kismet technique, you have the, you have the Alice, you have the Emma. So there are a lot of now techniques which have come in which you can analyze whether there's a normal or an abnormal environment as far as infections go in the endometrium, and you can appropriately treat.
Is it mandatory on Alice test before you start probiotics, or you can give probiotics for all your recurrent implantation?
I think probiotics being safe the way that they are, no harm in giving them. It's just that there are so many different combinations of organisms in the probiotics. So whether we have the right combination today or we don't, how does that work most efficiently? Does it affect orally best, or does vaginal implantation of the vaginal or whether it's intrauterine, somebody said. So we don't really know the best way forward. We just know that there's a lot more focus on this, and it's going to be very important in the future.
The test of Alice costs almost 25,000 rupees, I think, ma'am.
Absolutely. Absolutely.
So doing something like that. And
I agree completely.
And there was a question on intravaginal probiotics. Is there any experience from your side on that?
So you will say na ke we just want.
I think we discussed that.
We have started using oral as well as intravaginal probiotics. And I don't know, unless you really have a very good study telling you, before, after comparison, we can't tell. But there are enough studies in literature now which are giving a very good outcome following the use of probiotics.
Thank you so much.
I have a question for Dr. Purusham. Dr. Reka wants to know about artificial intelligence in endometrium. A few words about artificial intelligence in endometrium.
So probably I think there's not much I have read about endometrium being affected as of now, but what I can imagine is that if there was a way of determining which kind of endometrium is helping better implantation rates, what is giving you better implantation rates, then probably use of artificial intelligence can guide you when to transfer the endometrium based on what your endometrium looks like. So, today we are doing all kinds of hormone tests. We are looking at progesterone level. If it's more than 1.5, before ovulation, we would not, before the trigger, we will not do the transfer in that cycle. So similarly, or looking at the morphology of an endometrium, we are making a decision whether to put it in or not, but it's not so reliable. Sometimes out of desperation, we put in an embryo because the patient's endometrium is just not getting better, and we still get a success. So the question is that if we really want to know developmentally, maybe artificial intelligence will be able to tell us whether, as a functional endometrium, is it a good endometrium or not. I think the day will come when we'll have all that information, but today at least there's not much. Today there's a lot of papers being presented when you go to ESHRE, when you go to ASRM. Every year the number of papers coming in for artificial intelligence are going on increasing because there are a lot of studies happening, but it will take us a little while before a lot of data is available on this for us to be, quite using it quite effectively. So I think we need to wait a little bit more and we'll have much more information.
And not all of us are like Dr. Sonal Panchal Madam to be experts on ultrasound for endometrium. So probably artificial intelligence will help us much more in the future.
But I hope we can all afford that artificial intelligence.
Someone has asked how much improvement can we expect DHEAS use? DHEA. Oh, I think maybe
the DHA is not going to be showing a lot of wonders. When you give for about 3 to 6 months, you will get 1 or 2 good oocytes which are having good embryos. the quality of usage becomes better. So it's not that it's the ultimate answer. You don't get, somebody doesn't have eggs at all, you cannot create eggs because the eggs are all permanently gone, are going away. So I think we can only improve certain of these fertilizable quality of the egg and the embryo become better, because I'm finding I may get 3 or 4 eggs, but I'm getting 3 embryos. Otherwise, long back I never got. Out of 4 eggs, I'm getting 1 embryo and then pregnancy is low. So our aim should be to get at least 1 or 2 good oocytes. It's not that we'll get, number will be large. The number will be same, but at least improve the quality.
Quality.
Yeah.
Dr. Amit sir, are you there? There is a question about. Hello. There is a question on PCOS. Sir, to Dr. Amit, is pregnancy rate lower in older women with PCOS? Any change in treatment modality in PCOS older women?
So Amit there?
If Amit is not there, can I answer that question?
Yes, madam, sure. With pleasure.
If Amit is there, if I don't think he's there, but if he's there, he would. Is he there?
No, madam.
I don't think he's there, ma'am.
So what studies have shown is that, we always felt that PCOS women have many eggs and therefore they should be able to get pregnant much faster even after the age of 40. So there have been excellent studies done wherein they've shown that even though PCOS women may have more number of eggs, after the age of 40, it sort of normalizes. Whatever is the pregnancy rate in an older woman, it's the same. In a non-PCO woman, it will be the same as in a PCO woman. So it's not going to make a difference in terms. So age becomes the most important criteria, even in a PCOS patient. The only thing wherein we can help in a PCO patient, probably the cumulative pregnancy rates may be higher because we get more number of embryos when we are doing their IVF, and if we have frozen those embryos and we do a cumulative thaw transfer after that, we have done a freeze all, and then every time we just thaw and transfer, we'll get a higher pregnancy rate only because we've got more number of embryos, but otherwise it makes no difference.
Yes, ma'am.
Okay, ma'am, we have one more question from Dr. Ashima Sood. She wants to know whether too much of exposure of light when we use artificial intelligence and time lapse will be detrimental to embryos.
With artificial intelligence, you're not using too much of light. Artificial intelligence is a computer-based program wherein you feed in certain information and you get your reply based on the learning which that computer has done. It's something like, how much input you give into a person, that much is the output you get. The more we read, the more we learn, and the more we can provide. So in short, with a computer, when you're putting in data from your lab or from wherever, the age of the patient, etc., the morphology, by looking at the images, the computer can tell you whether this embryo, almost 90% of the time, tell you whether this embryo is a good embryo or not developmentally, because the data has been fed into them through millions and millions of embryos. Similarly, today with mammography, with pap smears, you're able to use a lot of artificial intelligence to help you to know which are the mammography reports which are likely to show you more problem or more chances of being cancer rather than being not cancer. So today a lot of mammography units are actually using it. So for oncology, it's been used quite a lot. For radiology, it's being used quite a lot. In assisted reproduction, as of now, we don't have too much, but there's a lot of research going on because, let's face it, ART has come in much later after radiology and oncology. So we need to wait a little bit, but the understanding is that it's a computer-based program wherein the computer has been made very, very knowledgeable. See, today I think with COVID going on, there are many people who have bought those robots to clean their homes because they don't have a maid at home. They are using the robot to clean the house. Now, those are again based on programs which have been built in. So that robot knows where to go, how to go, based on the design of the house. So in short, I think and we are all using it every day. We are using it on our phone. When we order an Uber, we know how far the Uber is. when we are ordering a test from a lab at home service, from the app, you can know where the person has reached to reach you at home. There are so many artificial intelligence apps today available, but they are in day-to-day practice. You don't see any light, you don't see anything, you just get information. So similarly, through artificial intelligence, it's not that there's extra light in the lab, it's just that you get extra information to decide which embryo is good to be implanted.
Got it, ma'am. Thank you.
So actually a comment, if we put in all the data which Madam Sonal Panchal has got in her books, that is artificial intelligence. You don't have to go after artificial intelligence. The artificial intelligence, the computer will interpret all the endometria that are there in the world and give you whether it's good or bad.
Absolutely, but then at the same time, they'll follow up that with that endometrium, what were the pregnancies they got. That whole data has to be fed in.
Yeah.
And then they devise these networks within the computer to give you an answer. So yes, all this data is extremely important. So we need to collect data. That's where we come to.
After this corona, whether patients will come to us, it will go to robots, madam.
Or we will be converted into robots, I think.
Aren't we sitting here and conducting a webinar, aren't we?
Yeah.
So this is going to be, digital education is very much there today to play. I mean, we have been doing webinars for years together. So much we have been doing. So I think sooner or later, yes, robots will be examining them and you'll give your advice based on what the robot tells you.
Thank you, Dr. Sanjeeva Reddy. Thank you, Madam Kamla and Madam Durusha and everyone who spoke here. And bye-bye for a very, and
I want
thank
to
you for a
tell
nice.
thanks, just 2 minutes. I will finish up vote of thanks. On behalf of Tapisar, I sincerely thank Dr. Kedar Patke, Dr. Sunita Tandulwarkar, Dr. Manish Bankar, Dr. Sanjay Makwana, Dr. Amit Patki, Dr. Reshma Pai, Dr. Pratap Kumar, Dr. Sonal Panchal, and Dr. Durusha for accepting our request and delivering excellent talks and clearing all the doubts. Also, on behalf of Tapisar, I sincerely thank all the moderators, Dr. Selambu Selvi, Dr. Kanchana Devi, Dr. Kanimuli, Dr. Ashok Kumar, Dr. Aruna Ashok, Dr. Kavita Gautam, Dr. Sharmila, Dr. Nirmala Vijay Kumar, and Dr. Arati for making the session live with your extracting many answers from the speakers. On behalf of Tapisar, I also sincerely thank the delegates for sparing their Sunday family time and attending this webinar, making this one a grand success. I also thank Jadis Pharmaceuticals for sponsoring the ECM, particularly Mr. Pradeep and Pudiyavan for coordinating from the beginning. I thank Mr. and Mrs. Technical team. Sahana, she is coordinating from yesterday from 8 p.m. onwards. Thank you very much for conducting this one without any technical hitches. Thank you very much. We hope again we'll meet after some time. Thank you for everyone.
Thank you. It was a wonderful webinar. Thank you. Thank you, Dr. Reddy.
Thank you, Dr. Sanjeeva.
Thank you.
Thank you, sir.
Thank you.
Thank you all. Thank you all.
Thank you so
Sanjeeva and
Thank you, sir.
Thank you. God bless.
Bye. Bye.
Opportunity. Thank you.
Shall we close or we want some more?
I can end the meeting for all if that is fine.
Okay. Sahana, you want to tell something?
I just said I can end the meeting for all if that's fine.
Okay. Thank you.
Okay, sir. Okay. Thank you, sir.